Actually, si Jeff ang meron sana eh. Teka, but we can start even without siguro the FB access for the meantime.
Ihabol na lang po.
Sige. You want us to start, Nems? With
Sige, we can start para on time tayo.
Pero yung access doon sa Facebook, hindi nila you want to start the program na?
Yes, we can. Tapos habol na
Sige.
lang natin yung access sa Facebook Live in a while.
Okay. Sige. Okay, so pleasant good afternoon to everyone and welcome again to day 3 of the Philippine Thyroid Association Annual Convention. This is a virtual convention. Of course, you're coming in on the 3rd day, but it's been a very productive first 2 days. We're very thankful for all our partners as well as our participants for joining us in the previous sessions that we've had. Today is another special day because we're going to cover some more important things about the thyroid. Of course, we're going to talk about very specific as well as very significant strategies on how to approach thyroid disease during the time of the COVID-19 pandemic. So here are the lectures for this afternoon. So the whole lectures will run between 4 to 6 p.m. today, and today is the 12th of February. We'll start off the sessions with the first lecture or panel discussion on thyroid malignancy in the time of COVID-19. We have 2 very distinguished speakers. We have Dr. Shoberg Ko and Dr. Wenceslao Lauderes joining us as panelists and speakers. And we will be moderated by Dr. Silvernon Israel, who will be joining us from Bohol. So this panel discussion will run between 4 p.m. to 4:45 p.m. The next lecture will be at around 4:45 p.m. The title of the talk is Robotic Surgery in Thyroid Disease at the time of COVID-19. Our speaker for this session is Dr. Jeffrey Geronimo Domino. The moderator for the session will be Dr. Domingo Sampang. Both of them will be joining us from Manila. So lastly, we have the final lecture and perhaps one of the most important strategic planning that you can do during the time of COVID. And this topic is called Telemedicine and Teleconsult Strategies for the Thyroid Patient. Everybody knows this speaker in the Philippines. And of course, he's already very known for his lectures all throughout the country. So Dr. Nestor Eric Laplano will be doing this talk later on in the afternoon. And he will be moderated by Dr. Arisa Crisan Soria, who will be joining us from Zamboanga City, down south of the Philippines. So later on, after we close the program, the closing ceremonies, we will have the induction of new members of the PTA, as well as recognition for our delegates, speakers, as well as moderators. We hope that you can join us. But for now, we will move on and start the first lecture of this afternoon. I'm showing you some of the pictures of the members as well as the officers and board of the Philippine Thyroid Association, of course, headed by Dr. Nemencio Nicodemos, our president, and Dr. Eric B. Cruz, who is our vice president. Joining the picture and completing the picture are Dr. Arnel Pauco, who is the secretary of the PTA, myself as the treasurer, Dr. Jeffrey Geronimo Domino, who will be lecturing later on robotic surgery, is the public relations officer. And the rest of the board will include Dr. Francis Estrada as one of our director, Dr. Ida Lim, also one of our director, joined by Dr. Eric Mendoza. And lastly, we have another speaker, Dr. Wenceslao Lauderes, our immediate past president, who will be joining the initial talk as panelist for the first topic that we have this afternoon. So let me begin by asking our moderator, Dr. Silvernon Israel, to introduce our distinguished speaker for our first talk this afternoon. Silver, are you ready to take over?
Yes, Doc. Thank you, Doc. Okay, so good afternoon once again. Welcome to the last day of our annual PTA convention. In behalf of the organizing committee of the PTA, I would like to thank you for gracing us again with your presence. So I'm Dr. Silvernon Israel. I hail from Bohol. I'm a diplomat of the Philippine Society of Endocrinology, Diabetes, and Metabolism, and I'm here because I will be moderating the first session of the 3 sessions that we have prepared for you today. Without further ado, it is my greatest privilege and honor to introduce to you our two speakers, who will be discussing cases and issues on the management of thyroid malignancy during the time of pandemic. Our first speaker is Dr. Shoberg A. Ko. He had his Doctor of Medicine at the University of Santo Tomas Faculty of Medicine and Surgery. He spent his residency training and fellowship training at Stony Brook University Hospital in New York. He is currently the chairman of the Department of Internal Medicine at the UST Hospital, a board examiner of the Philippines Specialty Board of Endocrinology, Diabetes, and Metabolism. He is also a current professor at the UST Faculty of Medicine and Surgery and currently the head of the UST Hospital St. Thomas Diabetes Center. So please help me welcome Dr. Shoberg Ko. Our second speaker is Dr. Wenceslao Lauteres. He had his Doctor of Medicine at the West Visayas State University College of Medicine. He spent his residency training in nuclear medicine at Jose Reyes Memorial Medical Center and had his master's in public management and health governance at the Ateneo de Manila University. He is currently the president of the Philippine Society of Nuclear Medicine, the immediate past president of the Philippine Thyroid Association, the chief of the Medical Professional Staff 2 at Jose Reyes Memorial Medical Center, and diplomate and fellow of the Philippine Society of Nuclear Medicine and Philippine College of Geriatric Medicine. He is also a faculty at the UST Faculty of Medicine and Surgery. So please give a virtual applause to Dr. Lauderes.
Good afternoon, everyone. Good afternoon, Silver.
Good
Wes.
afternoon po, doctors.
Yeah, good afternoon. Good afternoon, everyone. Good afternoon, Silver. And PTA, good afternoon.
So as I have mentioned, I will be sharing case scenarios to you later on, and the speakers will provide their opinion and give their management advice for their patients and their clinics. No? So I will start with my slide. So this pandemic has actually brought a lot of issues, considerations, and complications, especially regarding to the management of thyroid malignancy. And primarily because patients are afraid to go back to the clinic for follow-up, or even more afraid to have procedures and surgeries done to them, especially in this time. Secondarily, could be due to the cost, additional cost. So, but patients are recently calling up our clinics because they want to know the relationship of thyroid malignancy and COVID-19 infection. So, is there a relationship between the two? So, are people with thyroid cancer at greater risk for COVID-19 infection? So, let me hear from Dr.
So this is a common question, and we get calls from our patients who are previously diagnosed with thyroid cancer. And their concern is, do they have to take any extra precaution as a patient with thyroid cancer, just like any other types of cancer? So, but thyroid cancer, well differentiated, the majority of the cases that we encounter are not considered to be that immunocompromised. Generally, they do well. It's a very indolent cancer. And after proper treatment, majority of these patients are either cured or controlled, and they don't take immunosuppressants, for example. They're not going to get chemotherapy. So therefore, as a whole, although cancer patients are considered to be immunocompromised, especially people who are actively undergoing chemotherapy, thyroid cancer as a whole is not considered to be at a particularly high risk. And only those rare forms of thyroid cancer, the more aggressive ones that are undergoing chemotherapy or maybe some external beam irradiation, that may have some effects on their bone marrow that might be considered to be somewhat immunocompromised. And there's a particular study, there are a couple of them, but we'll quote one for today. Silver, can you move the next slide, please? So this this particular study that came out or was published middle of last year, looking at the impact of COVID-19 on patients with cancer. It's a cohort study of about a little bit more than 900 patients with different types of active and or previous malignancies, including around 30 of them with head and neck carcinomas, with unspecified how many of them included patients with thyroid cancer. It came from different countries. And this particular data, among those patients with cancer and contracted COVID-19, 13%, the mortality rate within 30 days was 13%. So was slightly higher than the average. Patients with progressing cancer were found to have 5.2 times more chance of dying within 13 days. And those with stable, non-progressing cancer was still associated with about 1.8 times greater risk of mortality when compared to those without cancer. So these are a cohort study. We don't know the comorbidities of these patients or the type of cancer that were included in this trial. So it does show that patients with particular types of cancer, especially those with active cancer, will probably will have a higher risk of mortality within the first 30 days.
Okay, so so that's the relationship between the thyroid cancer and COVID-19 infection. How about conversely, does COVID-19 infection increase the risk for a thyroid malignancy?
Well, at this point in time, there's no, remember, a lot of thyroid cancers are quite indolent, so it's a slow growth. So being that during the quarantine, a lot of these patients are just doing telemedicine and they're not going out. And so a lot of these patients do not get a radiologic tests to find out that they have nodule. Neither will we'll talk about when and who should undergo fine needle aspiration biopsy. So the dramatic, there are data showing that the number of consults for thyroid nodules worldwide went down during the first few months of last year compared to 2019. The number of fine needle aspiration biopsies went down also. So overall, we don't know. But my guess it does not, just because thyroid cancer generally is quite indolent, and the other reason is the other reason we don't know is the dramatic reduction in visits. So we really don't know at this point in time.
Okay, so we will now have the first case scenario. So I will read to you the case. So patient, a 49-year-old female who came in with a gradually enlarging anterior neck mass on the left for the past 5 years, which moves up with swallowing or deglutition. So she carries herself an ultrasound result that shows a 3 centimeter solid hypoechoic mass in the left lobe of the thyroid with clear borders and microcalcification, which is tagged as ACR thyroids 4. In spite these ultrasonographic features, there's no suspicious lymph node. TSH is normal at 0.6 ml/international unit per liter, and there are no obstructive symptoms such as dyspnea or dysphagia, and no symptoms indicating functioning thyroid nodule. So the issues and the frequently asked questions in the evaluation of thyroid nodule during the pandemic would be what are the considerations for deciding an urgent FNAB compared with postponing an FNAB?
Well, the issue here is if you look at the characters of this thyroid nodule in this lady, there's a clear indication to do a fine needle aspiration of that nodule. And the question, like you said, Silver, is do we do it now in the time of pandemic, or is that something that we can postpone? So, my answer for this time of the year compared to early last year, when the start of COVID-19, where people were really scared, patients don't want to see their doctors, and doctors don't want to see their patients. A lot of our colleagues did not even bother opening their clinic, and they really shut down and just telemedicine did not start out right away. Most of the physicians who started their telemedicine started their platform around May or June at the earliest, and then it just kind of picked up throughout the past several months. So my answer might be a bit different last year compared to this year, but let's look at some of the data and recommendations. Silver, so can you move to the next slide? So the question are often asked is if we do encounter, whether through telemedicine or face-to-face, is it safe to delay a biopsy of thyroid nodules? So these are recommendations from the Clinical Affairs Committee of the American Thyroid Association. And this is what they had to say. And, or they're still in their website, they said that their statement would say, and we should agree with this, that majority of thyroid nodules are going to be benign. Only about 5 to 10%, depending on characteristic of the nodule and the age, would be malignant. And most of this malignancy, to begin with, even if there's a delay of diagnosis, generally will not affect the mortality. In a few cases, it might affect the morbidity because it might change stage. But overall, delaying diagnosis or treatment for, especially for well-differentiated thyroid cancer, has not been shown to reduce mortality or so. Overall, we look at 2 points: whether it's going to be affect the morbidity, probably very minimally, mortality probably near zero, even with the delay of a biopsy. So we would like to evaluate beyond just a nodule. We'd like to look at the features for malignant potential on ultrasound using the thyroid scoring. So in our case, it's thyroid 4. Without pandemic, the patient that buys a pen, it's moderate suspicion for malignancy, and that buys the patient a fine needle aspiration biopsy. And the other issue would be, are there any obstructive feature that warrants urgency of evaluation of this patient's thyroid nodule? In our case, the patient was asymptomatic. And in other countries where they put a lot of emphasis on medullary cancer, in Europe, for example, anytime that you get a thyroid nodule, a serum calcitonin level is automatically part of it. In the States, it's not. And they will qualify who gets a calcitonin level. So part of the American Thyroid Association recommendation would say that who should, because since medullary is a more aggressive form of thyroid cancer, it might just change whether you're going to proceed with biopsy in this particular patient of ours or not. So if the patient had a family history of thyroid cancer or medullary endocrine neoplasia 2, then, or if the location of the nodule is typically where medullary thyroid cancer is commonly located, in the posterior upper third of the lateral lobes. And in that situation, you may want to get routinely a calcitonin based on American data. And if the calcitonin level is greater than 10, then that increases the suspicion that it may be medullary, a more aggressive form. Then you want to proceed to fine needle aspiration biopsy. And if the patient has greater than 100, then that's highly suspicious. And what they say is you probably should jump and go straight to total thyroidectomy without a biopsy. Obviously, during the intraoperative period, one can do a rush frozen to determine or confirm malignancy and to determine whether this patient with a unilateral nodule should undergo lobectomy or total thyroidectomy, depending on the result of the rush frozen section. So this patient did not have family history of medullary thyroid cancer, right, Silver? Wala, no?
Yes, Doc. Wala po.
Wala siyang MEN2. They're quite rare, but we have to ask. And the locations, if it's not typical of where medullary thyroid cancers are commonly located, then we can skip and not do calcitonin. It's somewhat expensive and not readily available, unlike the other tests for thyroid cancer, where fine needle aspiration is generally easy to do and readily available to in different parts of the Philippines. And there are other issues that one need to think about whether to consider whether you're going to do a biopsy or not. Next slide. Other issues. Patients, I have patients who, despite being told that it can wait, decided that they want to do a fine needle aspiration biopsy because they couldn't sleep at night, having not knowing whether they have a malignancy or not. So some patients, majority of the patients, are easily reassured, but some takes a lot of convincing. So in the end, we just recommend, and in this particular case, it could have waited, but some patients who are anxious and couldn't sleep at night, then we proceed and do a biopsy, because the patient have their own perception of nodule and malignancy, based on their own beliefs or their experience with their family members, maybe. Okay, so they recommend that you should get a special consent. That will include that coming to the hospital might put them at higher risk for COVID-19, and that should be part of the special consent at this time. And of course, one needs to consider what's the local prevalence of COVID-19. In some locations, Silver, you practice in Bohol. How's the COVID-19 situation there?
We have like 100 cases right now, no, active cases.
Active cases.
Yeah, there are towns that have increasing numbers, no, and that's actually close to the city, and another one is close to a secondary Department of Health institution.
Okay.
So, yeah.
So it really depends. If you're in a town or locality where COVID-19 is not that prevalent, maybe you should manage this patient as how you would usually do it in the non-COVID times. And you should consider PPE shortages, because a lot of institutions will require you to wear PPEs when you do this procedure. It's not considered to be aerosol inducing procedure. However, we do know that during needle aspiration, some people might cough if you irritate their throat a little bit. So they may cough a little bit. They're gonna have to wear a mask during the procedure. But one should need to consider their priority. Where are going to allocate the PPEs? Are you going to allocate just for doing a fine needle biopsy? Or is somebody else actually need to use these PPEs? And local public health directives, some local hospitals will have directives that you cannot do any procedures that are non-emergent. And so you have to follow local policies. I'm glad that this year we have opened slowly over the past 6 months. And we are now open in UST Hospital and many other hospitals. So we're accepting more patients. And we have a more organized system of delineating patients who are going to come in safely. And of course, each of us will have requirement, whether it's just a chest X-ray, a CBC, or a requirement for swab. Up until about last month, a swab was required for an ultrasound-guided biopsy in UST. I don't know in other hospitals, but that was removed. So we just now require CBC and chest X-ray. So that's about it in terms of biopsy. So for these patients with who's 49, even with lymph node metastasis, as long as we know the cutoff is 55 now, that if they're below 55, even with lymph node metastasis, they're going to be classified as stage 1 only. So only if they have distant metastasis, they're going to become stage 2. So overall prognosis in this case is going to be good, even if you delay in this 49-year-old with a thyroid 4 thyroid nodule. So
okay, noted, doctor. So going back to the case, another issue would be, is thyroid scan needed to decide for doing a fine needle aspiration biopsy?
Yeah.
Let me ask Dr. Lauderes for this question.
Good afternoon. Okay. Basically, for the thyroid scan is really the information you're going to gather from subjecting the patient for thyroid scan is basically providing functional information of nodes or nodules. Meaning to say, the thyroid scan can give you either it is a hyperfunctioning or hypofunctioning nodule. So basically, if we're just talking about the need for the thyroid scan for the FNAB, there is no role for the thyroid scan, as a basis or as a reference mark in deciding for the FNAB. Okay.
So perhaps the role of the thyroid scan would just be in patients who are especially thyrotoxic or have
Yeah.
suppressed TSH?
Yeah. So all you need to the need for the thyroid scan is if you want to assess if the particular nodule of interest is more of a hyperfunctioning or hypofunctioning. But the need to use thyroid scan as a basis for FNAB, it will be more on the thyroid ultrasound rather than a thyroid scan.
Okay. Okay, thank you, doctor. So let's move on to the next issue. So what's the role of TSH suppression while waiting tests to be done? So
So
can I ask
for
Dr.
example, Silver, if this patient, the question would say if you decide not to do a biopsy on this patient, is there a role for TSH suppression? And uh, we know based from data, unless a patient has elevated TSH and is hypothyroid, there's no role for giving thyroid hormone in non-hypothyroid patients, especially in these patients whose TSH is already in the low end of normal. Even during non-pandemic times, there won't be a role for giving thyroid hormone in this case. Sometimes if the TSH is 3 or 4, and you think the nodule is benign looking, you don't want to do a biopsy, we do try TSH and bring it down to the low end of normal and see whether the nodule might shrink in size. But not in this case. TSH is already in the low end of normal. Giving thyroid hormone will just make her thyrotoxic.
Okay, thank you, Doc. So we were able to confirm indeed needle aspiration biopsy revealed metastatic category 6 cancer. And patient is subsequently advised for total thyroidectomy as it is the appropriate surgery management for this case, but is currently hesitant because she wants to do the surgery in the city, and the number of cases in the city is increasing and making her anxious and fearful. If she can have the surgery at a later time when the number of cases are low. So the issues would
yeah.
be, do we observe and wait? So what are considerations during pandemic, or is a delay in the surgery would create an adverse outcome to this patient? So, Dr. Ko?
Okay, so if this is a case of last March or April or May, when hospitals are filled and the priorities are being given to the care of the beds, at least, and the care, because at that point in time, the RT-PCR came down. They're always delayed, and the classification were kind of confusing at that point in time. I'll say just wait. Okay, can you show the next slide, Silver? So generally, most of the recommendations, Silver. Okay, so question still is, in well-differentiated thyroid cancer, is it safe to delay surgery? The answer for most cases is going to be safe. And they are slow-growing tumors. And if there's a spread to the local lymph node, generally, we said that it won't change their stage. This patient who's 49 and below 55 will remain stage 1. And it should be, but however, they said that it should be performed more urgently in patients with symptoms of obstruction, for example. And if there's evidence of invasion to other parts of the body and possibly invasion to or distant metastasis, in the absence of any aggressive form, then the answer will be yes. Next slide, Silver. So the American Thyroid Association came up with a surgical affairs committee to address this. So they said urgent surgery, which is defined not to be delayed beyond 4 weeks, should be considered for thyroid cancer that are immediately life-threatening, that pose significant morbidity related to local invasion. We mentioned this, and that also exhibit aggressiveness, and showing a short doubling time, meaning a rapid enlargement in the thyroid nodule. A goiter with symptomatic airway compromise should be operated on. And if unequivocal, meaning if you do a fine needle aspiration and it's unequivocal and suspicion for a more poorly differentiated or anaplastic, and you need to do a core biopsy, then those type of patients will have to proceed with their procedure. And again, this has to be individualized based on your recommendation and your local situation. and your local preparedness in your hospital, and also, of course, how the patient feels about the situation. Next slide. There are other issues in terms of surgery, and this is one of the articles that came out about 20 years ago that says that during thyroidectomy and any surgery for that matter, there might be increased cortisol levels that might enhance the expression of anti-inflammatory genes in leukocytes, which might decrease production of many pro-inflammatory cytokines and make the patient immunocompromised. However, part of the problem of COVID-19 is too much cytokine. So this might be, in fact, we give steroids to this patient nowadays, but back last year, steroids was not part of the treatment. We were scared of steroid and making them more immunocompromised. But this year, over the past, I think 4 or 5 months, high-dose steroids is now part of the treatment to counteract cytokine storm. And this negative immunomodulation by cortisol, they believe, are also enhanced by catecholamines released during the acute stress. And on top of that, medications given during anesthesia and pain management might further cause immunocompromise to our patients. So, but the short answer is we don't know. Cortisol is taught 20 years ago as something, as a stress that make them immunocompromised, but yet we give steroids for our COVID-19 patients. So I think it's a non-issue at this point in time. And if the patient needs surgery, go to surgery. Silver?
Okay, so going back to our case, the patient has undergone total thyroidectomy and histopathology shows aggressive histology, which is an intermediate risk. So thyroglobulin post-surgery also shows elevated results. So the issues right will be, do we do post-op radioactive iodine? I mean, do we do it like the usual, or is it okay to postpone in this case? And if we administer RAI, is there an issue between a low dose versus a high dose RAI and a possible bone marrow suppression in this case?
Yeah, can you show the slides, Silver, please? Yeah, basically, just to delay the RAI for say 6 months or even longer do not appear to be negatively affect the course of thyroid cancers in patients. So more urgent for patients who have a papillary or follicular thyroid cancer, who have basically have distant mets to the lungs or other other body parts, particularly if growth of the metastases have been considered. Okay, we have the next slide. So if you can see here, on the issue that radioactive iodine really induced immunosuppression, you can see here that basically for 1 week, if you compare the effect of the radioactive iodine from 1 week, using if you refer it to the baseline level of WBC, hemoglobin, and platelet, you can see it is a numerically significant with a p-value of less than 0.001 during the first week. But this is more of the transient effect, because if you try to see it more on the 1 to 6 months, going to the 6 to 12 months, you can see here that the value is going back or stabilized, especially on the 6 to 12 months. So numerically significant, let's say during the first week, but clinically, if we're talking clinically significant or effect, basically does not pose a clinical threat to the patient. Okay.
Okay, Doc. I just have a question, Doc. If for example, a patient during an REI develops signs and symptoms of COVID-19 infection, does that affect the whole course of the radioactive iodine, or does that increase the risk for the patient for a critical type of COVID-19 infection?
So you're talking that during the course that the patient had radioactive iodine. No, basically the patient, actually for now we already have this updated recommendation on giving radioactive iodine on the home setup. But we sought clearance from the Philippine Nuclear Research Institute. This is actually the institute that regulate the use of radioactive iodine, So we actually submitted a letter asking for their consideration that because of the pandemic, basically during the pandemic, most of the isolation or private rooms have been closed, and there is really an issue of how can we be able to continue giving or providing radioactive iodine to those patients that urgently or badly needed the management. And the Philippine Nuclear Research Institute gave us the clearance that as long as we can be able to give as high as 140 MCI down, we can be able to manage patients on home setup, home setup, provided that they should at least follow some certain guidelines. One is they should be able to at least maintain a prudent distance of 4 meters away, without wall for 80 home members or domestic members, or 2 meters away with wall, or best to isolate them for at least 3 days. Second, they should, once took the radioactive iodine, should sleep alone in a room for at least the first 2 nights, and of course they should not be traveled for the next 3 days, and they should use a single bathroom for the first 3 days, and of course the usual, a lot of fluids, and as much as possible do the eating and do the rest of the personal necessities for the next 3 days alone. So basically, if for your question that will it affect on the management of the radioactive iodine, basically none. No? So
Okay.
we can still manage what is appropriate for that particular case of the patient, even though at that particular time the patient had COVID or have COVID.
For outpatient RA, high dose RAI, how do you plan to monitor these patients via telemedicine or?
Yeah, yeah, yes. Once the patient received the particular radioactive iodine for their particular case, now there should have at least there are a lot of virtual platform. Can be through Viber, can be through even a simple cell phone within the next 3 days, and better to have a video telemedicine consultation during every day on the day-to-day basis. And then after a week, they should go back. They should go back to the Department of Nuclear Medicine for whole body survey and needed appropriate radiation monitoring with just a simple CBC and chest X-ray result.
Okay po, Doc.
Okay, we have two questions here before we move along. Dr. Olbach asks up to how many millicuries are allowed as outpatient? Dr.
Yeah, up to 140 millicuries, doctor.
Okay, so that answers that up to 140 you can do it as outpatient based during the pandemic. And another question from a nurse, anonymous, says she's due for radioactive iodine this year. She underwent thyroidectomy and it was cancer. I suppose this is a well differentiated, that's why radioactive iodine. She's gonna get radioactive iodine. Her question, can she still get the vaccine once it's available?
Yeah, for me, there's no contraindication for it as long as the usual, if there's no symptoms at the particular instance during vaccination, and follow the certain COVID guidelines, no fever, no the usual. But basically, for the radioactive iodine as contraindication for the vaccination, I think there's no contraindication for it.
Okay, thank you. Silver?
Okay, so the third issue would be do we do
Silver?
Wala si Silver.
Okay. So let me just answer this. I think this is highlighted. If you're going to do radioactive iodine in this case, do we do withdrawal or do we use thyrogen? Can you move to the next slide, Silver?
hello?
Yeah, next
Yeah,
slide.
can you move to the next slide, Silver?
Yeah, I asked the question already. Your question, number 3 question. So thyroid hormones and its effect on COVID-19. This was part of the lecture of hypothyroidism a couple of days ago and hyperthyroidism. So thyroid hormones can exert response on diverse immune system that affects several inflammatory related processes. This was one of the questions earlier that was typed in on oxidative stress. And it's known that thyroid hormone can cause oxidative stress when in excess. So hyperthyroid state can in fact increase the release of cytokines. So the issue though, going back to the question of Silver, do we withdraw and make the patient hypothyroid? If you look and listen to the lecture a couple of days ago, it says that hypothyroidism in fact can make the patient immunocompromised, and there's a clear relationship between the endocrine and the immune system. And these patients who are hypothyroid should be given levothyroxine because it might make them more immunocompromised. So the question is, after 3 to 4 weeks, if you withdraw thyroid hormone, the patient will become hypothyroid before you deliver the radioactive iodine, they might just be immunocompromised. So my own personal opinion is if the patient can afford thyrogen, then after surgery, you give them the thyroid hormone, and thyrogen would be a preferred mode of therapy. But again, this is after decided that you're gonna give radioactive iodine to this patient. But this is my own opinion, and guidelines did not, the societies did not take any stance in terms of thyroid hormone withdrawal versus thyrogen. It's just that hypothyroidism makes them more immunocompromised. Silver?
Okay, so if we give thyrogen for this patient, doc, can we give it as early as like 1 week after the surgery when there's already the histopath result of
Yes. Yeah, you can give it as early as 1 week after rather than waiting 3-4 weeks in this case.
So this will decrease the exposure of the patient in the environment, in the city or in the hospital setting also. But of course, it has higher cost. No?
Mm-hmm.
So let's proceed with our case status post total thyroidectomy 3 years ago for PTCA stage 3. Previously with excellent response to therapy, now scheduled for follow-up today for thyroid cancer monitoring, but hold up and asked if she can move her schedule next year. For she wants to be vaccinated first before going to this. So she also asked if she can just continue with current levothyroxine therapy. So here are the issues. Thyroid cancer monitoring or postponed. We do stimulated TG versus non-stimulated, and how about doing a whole body scan or doing a PET-CT for monitoring? So for
there are also recommendations how about patients who are due for their monitoring after their therapy? Can you move on to the next slide? Okay, so should dynamic monitoring of well-differentiated thyroid cancer, such as this case, proceed as scheduled? They generally would say for low-risk papillary thyroid cancer, our patients intermediate risk, and only under active surveillance, delaying ultrasound can by about 4 to 6 months from the first year, and also another 6 months during the second year, because that would mean last year, a year ago, they must be negative. That's why you're doing a second year monitoring. So generally, delaying it by about 4 to 6 months is acceptable. Patients with excellent, in one data, it shows that patients with excellent indeterminate or biochemical incomplete response to treatment do not constitute a risk of group or high risk for COVID-19, and the frequency of structural disease is less than 4, 15, and 20% respectively. So generally, you have to classify patients if they are low risk and low chance of the thyroid cancer, despite not being completely cured, will affect them if you delay their monitoring or treatment. So again, in this case, 49, stage 1, probably, the answer would be, it's okay to delay.
So the non-stimulated TG shows elevated value at 40 and increased anti-TG from previous value. Whole neck ultrasound was unremarkable, and whole body scan shows no RAI uptake anywhere. So what's the role of FDG PET or other diagnostic procedures for this patient, and what are the considerations? Dr.
For me, for the whole body scan with no update, basically as a clean case without the previous radioactive iodine, the role of the FTG PET usually comes in if there's a whole body scan, is negative, but there is an increasing trend of the thyroglobulin. So, but as long as there's a whole body scan uptake, so definitely radioactive iodine plays a very crucial role on it. But in this case, with the whole body scan shows no RA uptake anywhere, FTG PET only sets in other than whole body scan is monitoring of thyroglobulin. But in this particular case, non-stimulated thyroglobulin value and increase from, yeah, you may consider the options of subjecting the patient for the FTG PET.
So going back to your issue of in monitoring this patient, should we do non-stimulated or stimulated? For me, you start with non-stimulated, because stimulated would mean making this patient hypothyroid during the time of COVID, unless a patient can afford a thyroid stimulated monitoring. So we decided the patient can delay by about 4 to 6 months. But if you should decide, because of the risk and of in agreement with the patient that to proceed, I'll start with a non-stimulated first, because just like this case, the non-stimulated by itself, you don't have to stimulate, shows it to be abnormal already. So it's a done deal already. There's a thyroglobulin elevated in somebody who underwent total thyroidectomy and radioactive iodine, and nothing was seen on ultrasound. You proceeded to do a whole body scan. Nothing was seen. But this is highly suspicious of a radioactive iodine resistant type of a papillary cancer. So let's go back to the question by Dr. Pataksil, that how often does a patient diagnosed with papillary cancer needs to do a thyroid scan as a monitoring, I believe? And generally we don't. We start with doing thyroglobulin and anti-thyroglobulin with the neck ultrasound. If the neck ultrasound is negative and your thyroglobulin and anti-TG are both negative, then that's done. You don't have to do a whole body scan. A whole body scan is done only if the neck ultrasound is negative, yet your thyroglobulin is elevated. And we do monitor more frequently during the first year. And if their first few years are negative, and the longer they are away from their diagnosis of thyroid cancer, the lower the chance they're going to be recurrent. So the frequency of monitoring becomes less frequent. Okay, so just to, because before we move on to, okay, so we answered most of the questions here. Let's move on.
Okay, so FDG PET shows mets to the lungs, and the patient is subsequently diagnosed with stage 4. Do we initiate TKIs, and what are considerations when we give TKIs in this patient, or what to do with patients already on multi-kinase inhibitors?
Okay, so for most part, if the patient, let's say during the monitoring, the TG was low and ultrasound was negative, that's the end of it. You just wait until next year to monitor them. And this case is unusual in that TG went up, okay? And this is a rarity that the patient will not respond to the surgery and the radioactive iodine, but we do see them. And in fact, even rarer is a radioactive iodine resistant, the whole body scan was negative, yet the TG was elevated. And the PET scan will probably show something. And in fact, in this case, it showed up on the PET scan, but not on the radioactive iodine whole body scan, showing that this is a radio-resistant papillary thyroid cancer. Then we're left with trying out multi-kinase inhibitors and in radioactive resistant type of papillary cancer. And these are the issues. And it's been shown that MKIs can put the patient at higher risk for neutropenia and lymphopenia, with increased incidence of about 5 and up to 13% respectively. And overall, severe hematological adverse event may also be enhanced by bone marrow damage caused by previous high cumulative dose of radioactive iodine. It's believed that Dr. West already said that a single, I saw that the data that that same article, that particular article was even given 150 millicuries, yet the white count really didn't go down except a little bit after 1 week. Different story if the patient underwent several, say 400 or 600 millicuries, then we're not certain how the bone marrows are responding in those situations. So Now you're adding MKI to somebody with high cumulative dose of radioactive iodine into their bone marrow. We don't know for certain, but that needs to be considered. Next slide, Silver. So this is a guideline that they came out with, and patients under systemic treatment should be considered as a risk group for COVID-19 infection and poor outcome. So patients who are on MKIs should take extra precaution in terms of not getting exposed to COVID-19. And the optimal time to start MKIs is always a challenge, since the impact on disease prognosis and impaired quality of life should be taken into consideration in decision making. And TKIs is not a cure for thyroid cancer. It is a control. If this patient's lung mets is just few and tiny, and the patient's not short of breath, I might opt to just observe this patient and not start TKIs at this point in time. So, but they have guidelines in starting MKIs treatment. And it says that as the usual practice, decision should be based on patient's performance status. So we talk about this, the patient's not short of breath, and tumor burden. If it's tiny, then probably don't. Disease progression, you can follow these patients with not PET, just looking at the X-ray. If they're grossly increasing in size using chest X-ray, that must be significant. You don't necessarily have to follow them with a PET scan. And symptoms is very important. So they say that avoid the delay in clinical imaging assessment for proper therapy initiation. So you just follow them. But patients who are on current MKIs, they said that the management should focus on preventive social isolation because they are considered to be somewhat immunocompromised. Not everybody will agree with this, but err on the safe side that they consider to be immunocompromised. They should isolate and not go out, just like elderly patients. Proper adverse events record with rapid and close interaction with the medical team by telemedicine mostly. And imaging monitoring should not be delayed to determine progression of disease if they so become symptomatic. So it's a close monitoring, and there are special situations, similar manifestations of COVID-19 disease should be considered. Any degree of febrile reaction. Some patients who takes MKIs initially might have fever, and if they do so after initiation, they should be tested for CBC and also tested for COVID-19 is what they're recommending. Next slide. But on the flip side, this is kind of interesting. They say that there might be potential antiviral activity of kinase inhibitors. So if you look at, they think, we know that the receptors for in the tissues for SARS-CoV-2 is using ACE2 in the surface of different tissues of the body. And they say that kinase might be a co-receptor for SARS-CoV-2. And say they're proposing that by using some of the kinase inhibitors, they identified some of them like imatinib. I couldn't even explain or pronounce some of this. They're so hard. Just look at it. But the one that we use for papillary cancer, sorafenib, is not part of the list for SARS-CoV-2, but was on the list for MERS-CoV, the Middle Eastern respiratory virus. And this is kind of interesting. So on one hand, they say you're immunocompromised, but there are data showing that in some types of virus, they might act as antiviral. So, but we don't know. And Silver, I think we have to wind down because we kind of started late, but we want to finish on time also. Silver, next slide, please.
Stop.
Next slide.
So I think this is the last slide though.
Yeah, the last slide. The question on people with really high-risk cancer who were given external beam radiation. And generally they say conventional external beam radiation used to treat tumors originating from non-lymphoid tissues based on the records shows an early reduction of CD4 and CD8 ratio, and there's some impairment of antibody production. So again, especially in people with a high cumulative dose of radioactive iodine, it might just add up. External beam radiation to to the body may make the bone marrow malfunction. So again, patients who underwent external beam irradiation, considering the immunosuppression status acquired after radiotherapy, patients who have previously received external beam radiation to the neck should be considered as an increased risk for severe illness with COVID-19. So therefore should exercise extra precaution and isolation and probably do telemedicine with their doctors more than face-to-face. So I think this is the last slide. Let's just
Yeah.
quickly, I don't see any new question. How much is radioactive iodine and side effects?
Side effects.
Wes, I think that should be the last
Yeah,
question.
for the
Question to
it's,
the answer.
yeah, for the radioactive iodine, actually there's a range of prices on it depending on the remaining thyroid tissues that should be ablated. So basically, we can give depending on the other than the specific cost for the radioactive iodine and with the corresponding PF. Probably depending on the for high dose, let's say 80 to let's say 60 to 80,000, more or less, without excluding, of course, of the isolation rooms that needed, just in case the patient will be admitted in the corresponding needed clearance laboratory before and after the therapy.
Okay, so I think that's it for this session. So in the interest of time, I'll wrap up the session. So thank you again, Dr. Ko and Dr. Lauderes, for giving us practical insights and enlightening us on the management of thyroid cancer during the pandemic. So indeed, there are a lot of issues, considerations, starting from diagnostic workup, the requirements for such workup, like for example, fine needle aspiration biopsy, up to the therapeutic part, including surgery and adjuvant RAI, ablation therapy. So I think, but the key message here is that in all patients, we should have appropriate counseling. It's mandatory that patients know about their condition and the prognosis and the options that they have during this pandemic. And the basis of most of our decisions should be made upon, of course, an individual or case-to-case basis. For example, the number of COVID-19 infection in the area, or the demographic profiles of the patient, if the patient is old or have comorbidities, and also the thyroid risk factors that we earlier discussed. So the key is just to balance really the risk and the benefit that will provide the best outcome for both patients and of course the healthcare providers. So I think that's it for this session. So I will be turning over the moderator to Dr. Sampang.
Thank you,
Hello,
sir.
Thank you.
Silver.
Thank you so much.
Thank you to both our speakers, Dr. Ko and Dr. Lauderes. And thank you, of course, to our moderator, Dr. Silvernon Israel, for handling that very, very intense discussion with regard to thyroid malignancy. Of course, that was a wealth of knowledge that Dr. Ko and Dr. Lauderes actually shared with you regarding the current management, particularly in the time of the COVID pandemic. Of course, we had to make some contingencies, and that's exactly the reason why we're having this conference, to have the ideas and suggestions, or even an extensive review of what data we have available. So we're moving forward to the next session, but before we move to that particular session, I'd like to welcome all our delegates as well as our participants from the various parts of Asia as well as the Middle East who are joining us through MedSynapse. We partner with MedSynapse to broadcast this particular conference to our delegates all over the world. In fact, we have some delegates coming in from Australia and Europe as well. So welcome to this session. We're now on the second lecture. I'll pass on the moderating job to our next moderator, Dr. Domingo Sampang, who will do the introductions for our next speaker.
Okay, thank you, sir. Good afternoon, everyone, and friends and colleagues. I am Dr. Domingo Sampang, a minimally invasive surgeon from Bataan, and it's an honor and a privilege to be a part of your convention and moderating the next session. To introduce our speaker, he is a graduate of the University of Santo Tomas Faculty of Medicine and Surgery. He had his residency in general surgery at St. Luke's Medical Center in Quezon City. and had his International Masters for Health Leadership and Master of Management at Montreal, Quebec, Canada. He is currently the head of the Division of MIS, Institute of Surgery of St. Luke's Medical Center, the Program Director of MIS Fellowship Program of St. Luke's Medical Center, Quezon City, and is the Chief Section of the Endocrine Surgery of SLMC. He is presently the Board of Directors of the Philippine Association of Laparoscopic and Endoscopic Surgery, and a member of the Clinical Robotic Surgery Association. Ladies and gentlemen, without much further ado, our next speaker, Dr. Jeff Domino.
Thank you, Dr. Sampang, and a pleasant afternoon to everyone. So let me share my slide. Let me see. Can you see the slides, Doming?
Yes,
we can see the slides.
Doctor.
Okay, thank you very much and good afternoon. So I was tasked to talk about the robotic surgery for thyroid diseases in the times of COVID-19. So this is now the day 3. The first day, Dr. Sarmiento did mention about the contingencies for thyroid surgery, and the lecture was very good. And in fact, I will be taking from that lecture to this lecture actually to talk more on the MIS as well as in robotic surgery. So, you know, see, the impact of the pandemic has really brought all of us into a different chaotic as well as, you know, different contingencies that we have. So that's why for the disclosure, I don't have any disclosure for finances, but the most of the data that I'll be presenting are usually new journals. Some are reviews, narratives, opinions, and even quotes. Because as you see, everything is new. Everything is, a lot of them are just reviews and the guidelines and even opinions. No? So we'll be presenting that in order to present the robotic surgery procedure. Now, the impact actually did put the Philippines into a code red sublevel 2, which means all elective as much as possible, whatever the surgery is, to minimize all elective and even just proceed with urgent surgeries. And some hospitals has even closed down their elective and just focused on being prepared of what the COVID, or if there is a surge of COVID numbers in the community. We even have designated hospitals for this, for the COVID-19 patients. And only a few hospitals were really designated as free zones for non-COVID patients. And this did limit surgical procedures only to emergent and urgent cases, causing a lot of delay. Okay, so that was what's happening last year. So for today, I will be giving you first a review of the minimally invasive as well as robotic thyroid surgery, the approaches in thyroid surgery, the platform about robotic thyroid surgery, so that we will I will later explain the importance of having this platform in times of COVID-19 pandemic. And what are the risks? Was it risky to really do MIS or robotic surgery during this time? And I will also talk about which surgery is safer for thyroid diseases and the contingencies as well as strategies. To give a background, the short background about thyroid, surgery for thyroid nodules, we do have what we call as minimally invasive thyroid as well as minimal access thyroidectomy. So besides the standard open thyroidectomy, these are now the new or alternative surgical procedures that our patients are now benefiting, such as the mini open to MIVAT or minimally invasive video assisted, as well as endoscopic, robotic, as well as the transoral endoscopic thyroid or vestibular approach, or the TOETVA, which I will give you a short description about that in a while. When you talk about minimally invasive, these are surgeries that utilizing small holes, okay, using special instruments. And through these small holes, we insert trocars to place over the neck, and guided by camera, we do the surgery in removing the thyroid gland. You could either do an anterior approach, lateral, or even a retroauricular approach. So these are actually described all around the world already and being done as well. Another approach we call the extracervical endoscopic thyroidectomy approach is the total axillary approach, wherein all the trocars are all in the axillary part, and we do the lift technique. And there's no gas here. This is just lifted, the skin is lifted, and the surgery is being done utilizing either the robotics or some endoscopic instruments. And then we have the anterior chest approach, and this is basically used especially if you want to do bilateral or total thyroidectomy, wherein you could easily access both sides of the lobe of the thyroid. So it's either anterior chest or chest wall approach, which we did about 2010 when we started this. And then we modified it, of course, the extracervical endoscopic approach, wherein we utilized the nipple areola or the breast axillary approach, wherein the trocars are more farther from the neck. And if you can see on this picture, definitely the scars are almost non-visible, and especially this will be covered by the clothes. Though we used a CO2 or a gas just to be able to access the area of the neck. And however, the patient does have a good scar healing for this type of approach. Okay. Now, the TOETVA or the transoral endoscopic thyroidectomy is actually accessing it through the vestibular part of the lower lip. No? So that way, all the procedures or all the instruments are passed through this area, and then the thyroidectomy is being done with the guide of the camera, and then eventually the visualization will be very clear. And you can see in this here, we are guided of what was visualized in the monitor. Again, the good thing about this, patient can really claim that there was no skin scar in any parts of the body, as the whole thyroid procedure is done through this approach. Okay. And then the robotic surgery platform. So in the Philippines, what is available to us is the Da Vinci SI, wherein if you noticed on this platform, the robotic okay, yeah, there. The robotic platform is that the camera and the three working arms are the one that is in contact with the patient, while the surgeon or the doctor operating the robot is actually on a distance. So which means there is no close contact with the patient. And with this type of surgery, a fewer staff are only needed, since there is already a robotic platform that can handle the camera, the retraction, and even the needed movements during the surgery. And this is the main parts. We have the surgeon's console, the vision card, and the patient card. So the minimum number of persons or healthcare within the operating room is basically around 4, which is the surgeon, the assistant, the nurse assist, as well as the anesthesiologist. And with this, you minimize the number of patients inside the operating room, which later on I will discuss the importance of having the number of healthcare inside the operating room. The advancement of the minimally invasive as well as robotic surgery has really shown that it has advanced into different procedures, from gastric, thyroid, colon surgery, hernia, prostate, gynecologic surgeries. No? And so far in the Philippines, more than 1,000 procedures has already been done. And we are one of the highest here, especially in the country. So when you talk about robotic assisted thyroidectomy, just to show you some of the videos, okay, you can see how precise the movements are. You can see how clear the visual and image are. And you can see also, while doing that surgery, the surgeon actually is on the console. So the surgeon is not very near the patient. It's actually, there's a certain distance from the patient, between the patient and the surgeon. And you can see that the only person that is near the patient besides the robotic arms is the assist. Okay, so besides a lesser number of hospital staff, The OR, you can do it's minimal access surgery. It's a robotic platform. Visualization is clear, and the surgery or the procedure itself is very feasible, and it can do the procedure for total thyroidectomy. So that's the beauty about this. So basically, the advantage of this robotic assisted thyroidectomy is that these patients enjoy the benefit of having not only removing the whole thyroid gland, whatever the indication is, but also enjoyed the no scar or no neck scar after the surgery, which actually, based on studies, has provide satisfaction and added satisfaction to the patient. Okay, so what now are the factors that makes MIS as well as robotic surgery risky, not during the COVID-19? When this paper came in, and this paper was around, I think it's about March. This paper coming from Wuhan, as they were the first area or country, as well as the first city, the Wuhan city, had the COVID-19. And they had this paper wherein it showed that they did an elective surgery for 34 patients with a median age of 58, starting from January to February of last year. And what they found was that all of their patients who are positive, who underwent elective surgery. At that time, it was the height of their COVID-19, and they were still doing elective surgery, and they found out that all patients who are COVID positive and underwent elective all developed complications. Even 44% required ICU, and 20.5% was had a mortality. However, if you look at on this side, these were the different procedures ranging from the minor to the major types of surgeries. Though they did not report any thyroid procedures. So mostly these are procedures mostly in the abdomen, and however, most of them are in the level 3, 2 to 3 procedures, which are major procedures already. So because of that, and because of that paper as well as the reports, the American Thyroid Association at that time have issued their guidelines that they should postpone for thyroid surgery. Elective surgeries are postponed to minimize the risk of transmission of the COVID-19. It's either we delay or wait longer for patients, especially those needing in elective thyroid surgery. However, if there are urgent or thyroid needed emergency or thyroid, I think this was already discussed by Dr. Schoberg, that not to delay urgent thyroid surgery more than 4 weeks. And who are they? These are thyroid cancers that are imminently life-threatening Graves' disease, or uncontrolled by medications, goiters with an impending airway compromise, pregnant patients with thyroid-related disorders that are dangerous to the fetus or mothers and uncontrolled by medications. So these were the guidelines by the American Thyroid Association last year in response to that paper as well. So because of that, we cannot just delay and wait. And nobody said when. Nobody was mentioning when are we going to wait, delay until when. And so the American College of Surgeons also set some guidelines on when can you resume surgery. And for them, for patient-related COVID-19, it is important to have policies, policies wherein you should screen your patient and test patient even entering in the hospital facility. For elective patients, it is best not to do COVID-19, but focus on the non-COVID-19. And that's why you have the screening test. And you also have some screening policy protocols for people who have screened positive. So in other words, you really have to choose the patients. It was also recommended to have mitigation strategies, by using, of course, the mask, and even having a patient visitor mask policy inside the institution. and to even have COVID-19 informed patient program, no, to really educate the patient about the conduct when they do their elective surgery and to avoid complications. So these were some of the mitigating or strategies or contingencies that was prepared or that was done and recommended by the American College of Surgeons in order to answer the scare or the fear of having a surgery in during those COVID times. And then in terms of minimally invasive, okay, minimally invasive surgery during a community spread and pandemic, this was the recommendations of the endoscopic laparoscopic surgeons of Asia. For them, patient selection and the strategy for surgery is done through, first, you have to check your active community, your environment. If you do have an active community is overwhelmed by a lot of COVID, then maybe limit all elective cases, okay? While if you have limited community but a spread and ICU capacity is good, you could allow cancer or trauma or even obstetric cases. While for isolated or mostly imported cases, meaning the number of your COVID cases within your environment or within your area, you could proceed with all the elective surgery, but you have to consider delaying the non-urgent and oncologic cases. But for some countries, no, that there are no active COVID-19 or no active alerts, they go back to the normal surgical procedures. So, in other words, the level of community spread, no, could help determine or will help determine if you're going to do your elective thyroid surgery, especially in minimally invasive surgeries. Okay, so another issue that makes this surgery of especially in minimally invasive and robotic surgery is the characterization of the smoke generated during the surgical or surgeries or laparotomy surgeries. This study have shown that surgical smoke prevention should use smoke evacuator for healthcare workers and should wear highly efficient tight seal fit masks in the operating room. And they did a study and measure the particles of smoke, no, within the operating room. And you can see that from before the operation, at the start of the surgery, and at the height of the surgery from 10 minutes using the surgical or the electrosurgical instruments during surgery, you can see how high the number of particles that are measured within the operating room. So the problem there is, what if there is a COVID patient? Will this smoke, no, be able to harm the health workers within or inside the operating room? And this was one of the risks that made the other societies during the early days of the pandemic that we have to first really select or do only emergent or urgent surgeries and delay elective surgeries as well. Now, of course, other concerns about that gas, no, and then this study have shown that the concern that is raised about the CO2 or the gas, no, that could theoretically contain COVID-19 particles and that aerosolization could expose healthcare workers to infection is if there is unrestricted release of the CO2 in the operating room. So that was one of the concerns, especially in minimally invasive surgery. However, the risk is definitely higher, and they say also that is the risk higher in laparoscopic than in traditional open. So this statement on the risk is based on the assumption that COVID-19 is present in CO2, and even now, up to date, no paper has not established that. So there is actually no paper that really showed evidence that there is a positive or a virus in the CO2 that is being emitted during the MIS or robotic surgery. However, this information presented in this report is more on an expert opinion rather than a robust data. Therefore, there is very little evidence regarding the relative risk of minimally invasive surgery versus conventional approach specific to COVID-19. So the risk is minimal. And let me show you this paper after this. So if you're going to have the surgery of the patient for thyroid, which is now safer for healthcare workers? Is it open or laparoscopic procedure? Now, this paper have shown that few studies have been performed on viral transmission during surgery, but to date, there is no study that demonstrates that it suggests the ability of a virus to be transmitted during a surgical treatment, whether it's open or laparoscopy. So there's no evidence. However, of course, there's no consensus on limiting or restricting laparoscopic or robotic surgery, but there is expert consensus on the modification of the standard practice, which means that despite there's no evidence, erring to the side of caution, we still have to perform and minimize any risk of transmission. So what's an example there on this view, on this image? You can see here at the above, this is the patient on surgery, and this is if there is COVID here, okay? For open surgery, the protection of the healthcare workers, okay? Either they could do a smoke evacuation as well as the PPE that's being worn by the healthcare workers. This is comparing open and laparoscopic. But for laparoscopic surgery or endoscopic surgery utilizing a pneumoperitoneum, the abdomen or the space that is being done for surgery is contained. Okay, and not only that, the pneumoperitoneum or the gas that being used to surgery is a closed circuit. Okay, it means you can control the flow of the smoke as well, the flow of the gas as well as the smoke. You can even they even use ultrafiltration, because it's a closed circuit, and then plus the PPE of your healthcare workers. So you can see, comparing the open and the laparoscopy, that the degree of filter as well as the protection is more in patients having a endoscopic or minimally invasive surgery. Now, so what are the contingencies now for robotic thyroid surgery during this pandemic? In robotic-assisted surgery, it has been shown that RAS, or robotic thyroid surgery, or robotic-assisted surgery, helps to reduce the hospital stay of patients that urgently needs complex cancer surgery, making room for COVID-19 patients. So this is in general as a robotic procedures. In comparison to open or conventional lap surgery, robotic-assisted surgery potentially reduce not only the contamination with body fluids and surgical gases of the surgical area, but also the number directly exposed the medical staff. And just to show you that, they compared the open surgery, the laparoscopic or minimally invasive surgery, as well as the robotic-assisted surgery. And the area of risk, wherein for robotics as well as for open and conventional, like if it's an aerosol producing procedure, the smoke, the body fluids, the pressure of the abdominal pressure that is used during the surgery, even the instruments, the staff, and the hospital stay. And you can see that between open and laparoscopy or robotic surgery, the smoke is confined and is filtered. The aerosol is limited, and because of the fiber of the filters or the locks. And there is a large surface of robot or limited number of instruments are less contaminated compared to the open. And basically, if you look at the staff are lesser in robotic surgery as well. So this is just to compare in terms of the type of procedures during, or the contingencies during COVID-19 pandemic. Now, how about, this is a statement from the American Association of Gynecologic Laparoscopy regarding the use of robotics, and there is no available evidence or from prior global epidemics to suggest that respiratory viruses such as COVID-19 are transmitted through an abdominal route from patients to healthcare. So again, can patient transmit? So far, there are no robust data for this, whether it's abdomen or the thyroid. So how about the use of high protection level for patients? For the assistance of the surgeon. Okay, so these are the levels of these are parts of the contingencies, and of course, you all still erring to the side of safety, we try to reduce the number of staff at the operating room. We need to ensure safe and effective gas evacuation, especially during laparoscopic or robotic surgery. We try to reduce the intra-abdominal pressure. And surgeons should avoid contact outside the theater in both in and out of the hospital. So these are just some of the contingencies that was made. And therefore, key points from social statements that was published. There is no current evidence, there's no current evidence that to demonstrate COVID-19 in the CO2 plume or created during minimally invasive surgery. So even now, we're trying to look for data or journals to really see if it's we as a surgeon, are we at risk doing surgeries for these patients. There is no clear evidence also that active virus is in the bloodstream in COVID-19 infected patients, as well as in the same report was found in feces, but there was no viable virus. So there was a report that they found that there was a trace of COVID-19 or RNA found in fecal material, but it was so far based on that data, there was no viable virus. There still remains uncertain regarding the presence of active COVID-19 that is outside the respiratory tract. So still very low in the evidence in terms of the patients. And then another key points is that viral exposure and transmission has been documented in limited prior studies laparoscopy and laser procedures. But this has not increased. The number of studies of this has not really increased. And they are unaware of any reports of COVID-19 related fatality of healthcare workers that is directly attributed to MIS. So even here in the Philippines, we also track our healthcare workers, the surgeons, the nurses who are undergoing surgery. And so far, there are no reports of fatality related to COVID-19 during surgery. The concerns put forth by statements from SAGES and the Royal College of Surgeons may discourage surgeons from performing MIS, but it has discouraged actually, but it was no adequate evidence for this. And the alternative to MIS or open surgery, when you talk about is it better MIS or open, it's still not without viral transmission risk to the healthcare team and increase the burden on the healthcare system by increasing hospital bed capacity as well, especially with a longer length of stay for open surgery. When you talk about MIS, it is still superior to open surgery with regards to patient outcomes across many disease states, and conversion to open surgery represents a deviation from the standard. And because of that uncertainty surrounding COVID-19 in the CO2 plume, measures to decrease the viral exposures to the surgical team should be performed. So we still need to do or wear our PPEs as what is recommended. And what are the mitigation strategies now? After hearing all those different journals, now it's important that when you talk about MIS surgical approach, it offers a significant advantage with respect to both the patient care, the mitigation of the risk of viral transmission during surgery, as well as providing the appropriate equipment and expertise if they are present. Surgeons are being now asked to adapt their practice to medicine based on scant evidence, since, again, these are all new to us as COVID-19, we are still in the middle of the pandemic. There is perceived risk of aerosolization of intraperitoneal viral particles. However, during surgery, aerosolization can result from dissection with electrosurgical instruments, but as the heat of such devices results in a plume of surgical smoke, although the risk of viral infection of the surgeon is well documented in open surgery, still no such literature exists that it is harmful to the healthcare workers, including the surgeon as well. So just to show you that even in cardiothoracic robotic assisted surgery, they did show here that there is still, though it has various advantages such as early recovery after surgery, shorter stay, okay, there's still no specific recommendations that are available for patients with COVID-19. And in other words, the procedure for this still are being performed. Okay, so I asked, I had my one of our professor or one of my friend from Seoul National University in Korea, Professor Han. So we asked him, we interviewed him, and has your robotic thyroidectomy in Korea really stopped, or did it really was it affected during this pandemic? They didn't have data yet. They're still compiling data, but for them, they continued to perform this robotic thyroid surgery even during the pandemic. And he told me that it's because the number of community spread in Korea is not that high. So that's why they still continue with the elective robotic thyroid surgery. They did not change their protocols. However, they did add mitigation measures, as mentioned a while ago. And it's because they do have a low ratio community in infection. So I think in conclusion, patient-related measures during our COVID-19, especially when you perform or we're planning to perform robotic thyroid surgery for thyroidectomy, patient-related measures are important. You still have to screen patients. Of course, since thyroidectomy or most of the patients who are going to undergo thyroid surgery are not immediate or not urgent, we could delay, and we could always screen the patients first. Proper selection of patient versus elective and urgent. So we should know which one we can operate or not. And we have actually proceeded with surgery. We have resumed our surgeries since late of last year. In terms of healthcare and staff preparedness, we could still continue mitigation measures like masks, smoke filters, despite no evidence of transmission from doctor to patient and vice versa, patient to the doctor. There's still no evidence, there's still no robust evidence that smoke or plume can really affect with this. However, we still of course go to the most safe part, or we still have to be cautious. And that's why safety checklists and pathway protocols should be done if you're planning to proceed or to resume your surgeries at this time. And of course, it's important to have the team skills and expertise within your institution. Also, the facility environment capabilities are important. You should have operating room contingencies, as I mentioned a while ago. You can also have the negative pressure rooms, your proper OR operating room setup. Okay, you should have proper hospital policies, especially for COVID-19. Of course, should have the right technology and the right supplies that is needed. And as I mentioned in one of the papers as well, if you have a low ratio of community infection or area of infection, then it's okay to proceed to your elective surgery as well. And therefore, robotic assisted thyroidectomy may continue to have a role even during COVID-19 pandemic, as long as you have mitigations, measures, strategies, as well as the contingencies that was mentioned a while ago. And this is all because the benefits of robotic thyroidectomy adds to the patient's satisfaction of having no scar even after thyroid surgery. So I think that's it. That's my last slide. So with that, thank you very much for listening, and we're open to now to more questions. Thank you and good afternoon.
Thank you very much, Doc Jeff, for that very well explained and comprehensive lecture on the different approaches to thyroid surgery. I'm sorry. Sorry. Can you hear me now?
Okay.
Can you hear me? Okay. Thank you very much, and congratulations, Doc Jeff, for that very comprehensive lecture on the different approaches in thyroid surgery, especially during this pandemic. In as much as I want to ask a lot of questions, in the interest of time and to give way to the next speaker, probably we will just be asking 3 questions. If it's okay with you, Doc Jeff. Since you have shown the different approaches and there's not much data with regards to the COVID-19 in aerosol and its risk, personally, what do you think would still be the best, safest, and cost-effective amongst these 3 procedures, whether an open or minimally invasive or robotic surgery?
Okay, so first of all, you have to, thank you, Doming, for that question. First of all, the patient factor is very important. No, number one, the type of thyroid procedure, if it's going to be total or with a modified radical neck dissection or just lobectomy. So that's one factor. Second factor, of course, you have to ask the patient. No, if you can do all three, the endoscopic or laparoscopic, the open as well as the robotic, and the patient has on the right criteria, meaning it can be done in any three, then you should also ask the patient which one is more preferable. And that way, you customize your best type of and safest procedure based on the patient's profile as well as preference as well. Because any three actually could be done. Of course, they have their own pros and cons. Of course, some would say it's faster to do it open. That's true. And it's also more safer to do in robotics because you have more precise movements, and you can still have surgery with endoscopic or laparoscopic without a scar. So there's a lot of pros and cons. So there's no one procedure that would really supersede each other, but it will really depend when you talk to the patient.
Okay, thank you. Another question, Doc Jeff, is that a lot of our elective patients were supposed to undergo surgery are being requested with RT-PCR. Is there any protocol for surgeons as well who are going to do the surgery even if they are not symptomatic?
That's right. No, that's one of the challenge actually, because it depends on the facility where you are. No, so definitely for patients, we have to, when we screen patients, one of the screening is the RT-PCR test. And that way, since thyroid or most of the thyroid surgeries are elective, if it's negative, then we can proceed. If it's positive, we can delay the surgery. And again, retest the patient maybe after 14 days, or after at least 14 days or 2 weeks. And if it's really the patient has gone now to a negative RT-PCR, then you can proceed to the surgery. But your question also is about the surgeon. No? That's important. Now, it is now the responsibility, first of all, responsibility of the surgeon. Of course, you should know as a surgeon, as a doctor, if you are exposed to COVID-19. Second, if you are or having some symptoms. No? And that's why you have the facilities have declaration health forms as part of the screening as well. And third, if you think that you are vulnerable or the patient is vulnerable, you can have the test as well. However, there's no study that has shown that an RT-PCR or a routine RT-PCR for the surgeon could help as well decrease or protect it, because it has shown that even with a random or you did a routine, there's not much difference. So maybe even in our hospital, it's not that routine. However, there are certain types of mitigations.
Thank you. I think my last question would be a very practical one. We all know that this pandemic has brought a lot of increase in the hospitalization bill of our patients. And one that suffered basically is the operating room because of the adaptive changes that were made in the operating room. My last question is cost-effective pa ba, Doc Jeff, kung magpapa-robotics? Most likely, tumaas ba ng sobra to the point that it's still affordable for others?
Thank you. Okay, so the cost for robotics actually did not increase as before, because we don't do robotic surgery for patients that are COVID positive. So if not for COVID positive, the minimum PPE level that we do or we use is level 3, no? And level 3, it's almost the same as that when we use. The only difference is that we have a face shield and a N95 mask. And other than that, it has no other additional PPEs, because the PPEs, the full level 4 PPEs, are only used for COVID positive patients, but we don't do surgery for COVID positive patients. So that's why it has not really changed a lot. Yeah.
Okay. Thank you so much, Doc Jeff. And I think with that, we're going to conclude our session and we'll be proceeding to the next speaker.
Thank you. Good afternoon.
Thank you.
Thank you, Jeff, and thank you, Dom. Another interesting session. I think that it's very important that we do consider options for our patients, particularly because we do have limited exposure and probably some more things to consider, especially during the time of COVID. As we move to our last lecture this afternoon, I think this is one of the more important topics that we really need to cover. The fact that there's limited face-to-face interaction with the patient as well as the physicians. Telemedicine has played a significant role in the past few months, if not practically the whole year since the start of COVID. And it's very interesting that we have one of the very good speakers in the Philippines, as well as one of the masters of telemedicine. So I think that you will all enjoy, and we will look forward to the lecture of our next speaker. I'll ask the moderator for the session this afternoon, Dr. Riz Soria, to introduce our next speaker for the lecture on telemedicine and teleconsult strategies for thyroid patients.
Thank you, Dr. Robles. I am Dr. Ariza Crisan Soria, a diplomate of PSEDM and currently practicing in City of Zamboanga. And I will be the moderator of the next lecture. As mentioned, we are now on the final session of this year's annual PTA convention, but definitely not the least, and in fact, a very important topic. Our speaker is a consultant of endocrinology, diabetes, thyroid, and other important metabolic and hormonal disorders. He completed Doctor of Medicine, residency, and clinical fellowship training at the University of Santo Tomas, and had his postgraduate research fellowship in medical neuroendocrinology at the National Institutes of Health in Bethesda, Maryland, USA. He is a diplomate and a fellow of the Philippine College of Physicians and the Philippine Society of Endocrinology, Diabetes, and Metabolism. Presently, he is practicing in Skyline Hospital and Medical Center and Grace General Hospital in San Jose del Monte, Bulacan. He is the head of the Thyroid Advocacy and Study Council of PSEDM, a medical bureau of the Philippine Center for Diabetes Education Foundation, and the director of the Philippine Thyroid Association. Ladies and gentlemen, our speaker is none other than Dr. Nestor Eric Laplano.
Thank you, Dr. Soria, for that very generous introduction. I'm just going to share my slide. Good afternoon, everyone. Okay. So I would like to thank everyone for staying up to this point. And I would like to congratulate the Scientific Committee of the Philippine Thyroid Association for a very successful virtual annual convention. So we have learned so much in the past few sessions, but of course, we cannot put them into good use if we actually do not see our patients. No? So, and at this time, we mostly rely on teleconsultation. The widespread use of telemedicine during the COVID-19 pandemic has pushed telehealth into clinical areas of endocrinology with actually paucity of data or published data, such as in thyroid disorder management. One plausible explanation for the limited data on the management of thyroid conditions via telemedicine is a lack of easily measured short-term outcomes, which may make objective comparisons between telemedicine and our usual face-to-face care more difficult. Unlike diabetes care, where the role of telemedicine has long been established and has translated into improvement in glycemic control, very few telehealth modalities have been explored to enhance specific aspects of thyroid care. And so despite this limitation, the use of telemedicine has rapidly expanded to uphold the safety strategies of physical distancing and COVID transmission reduction while still maintaining the uninterrupted care of our patients with thyroid disorders. And so for this afternoon, we shall foray into rather uncharted waters as we review the generalities of telemedicine relevant to thyroid disorder management. Since providing safe, effective care with our patients' best interest in mind should still remain the first goal of telemedicine, we will also discuss some strategies that may be applicable to a virtual consultation. And since I have the privilege of having the last words for this convention, we shall try to synthesize practical aspects of an effective online management of thyroid disorders. So in this teleconsultation guidance for Filipino clinicians from the University of the Philippines College of Medicine Medical Informatics Unit, the group of Dr. Iris Isiptan, another endocrinologist, has laid out the following generalities to ensure quality care even with remote consultation. So before teleconsultation, remember to prepare your technical setup, what platform you will use, whether you will use an audiovisual or just an audio type of telemedicine. You determine if the patient is suitable for telemedicine. Now, most of our encounters at this time will be to reassess or monitor already known patients, including maybe adjustment for their doses, evaluation for improvement of symptoms, or checking for adverse drug reactions. Patients, for example, presenting with severe upper airway obstruction or severely hyperthyroid patients may not be suitable for this type of telemedicine. Prepare the patient's previous medical records and review them well, because our patients will definitely expect us to have already seen their records once we talk to them during the consultation. Inquire if the signal or the audio or video is clear, both on your and your patient's side. Give introductions, make sure that you are talking to actually the patient and not someone else. And of course, family members or other companions present should also be introduced. Most importantly, secure consent for the teleconsultation. During the consultation, the patients should be informed adequately of the teleconsultation process and its limitations by explaining how you will get the information you need for the diagnosis and treatment. Conduct a very thorough history, including your past medical history, surgeries of the patients, prior radioactive iodine therapy, any comorbidities, medicines that may affect the thyroid function, any recent infection that may preclude to your thyroiditis, as well as family history of any thyroid disorders and allergies to medications, and a good ROS or review of systems to point to a specific thyroid dysfunction. Part of your website manners is to express empathy and be aware of facial gestures, vocal quality, and tone. Now, inform the patient when you are occupied, such as writing notes. Excuse me, let me just write down what you have just said in my documentation. You can always say that as part of your website manners, or looking at radiologic images at their lab results. Summarize, very importantly, the key points and ask for any clarifications. Have the patient repeat back what they understood in your conversation as a form of your reflective listening. Of course, after the teleconsultation, you explain very well your plans for your laboratory and ancillary procedures, and especially your prescription and plans for follow-up. Arrange for a face-to-face consult or give instructions to go to the emergency room just in case there is worsening of their symptoms or any emergent conditions. Give a clear sign to the patient that the visit is coming to an end. Put a good closure and take the patient. Get the patient feedback, and most importantly, complete your documentation. So at the minimum, what are the requirements for your telemedicine setup? You will need a landline phone, a cell phone with or without camera and or computer. If using your video or chat software, a stable internet connection is vital. In low resource settings, majority here in the Philippines are classified as low resource setting. The telemedicine services may actually just consist of only of landline phone calls, cell phone messages, or even SMS. For a video conference, a cell phone camera with approximately 5 to 8 megapixels would allow a match rate of 85 to 90% as compared to your face-to-face diagnosis. With the increasing use of smartphones, people have used these apps even before the pandemic to communicate with your physicians. Of course, many of you are also using different telemedicine platforms. Although these platforms and apps are compliant with the HIPAA, it is important that you should inform patients for potential privacy risks. No, public-facing apps such as your Facebook Live or TikTok should not be used to provide telemedicine care for your patients. So we've seen a lot of faces, or we've made a lot of faces in our telemedicine consultations with this, no? To attain the clear audio and video for the teleconsultation, a minimum bandwidth speed of at least 2 Mbps should be used. Again, test the video and audio quality and anticipate any potential technical difficulties that may cause interruptions. Keep in mind that we can only examine these patients as they would appear and talk to us on screen. Now, in addition, you should be mindful of your patients' varying internet speeds. As such, you should give approximately 2 seconds of lag time after your patients have stopped speaking to allow all of their words to come through, and of course, vice versa. So you let them finish first, or you ask your patients to let you finish first and allow at least 2 seconds of lag time, because there may be a lag in the signal, for example, while you are talking to your patients. We've seen a lot of our patients presenting with this. Now, it is likewise important for you and your patient to be in a private, well-lit room that is quiet, so that you can hear each other very well, thereby maintaining privacy, unless you want everyone in the neighborhood to hear all your patients' maladies. Now, a white light is recommended, and other sources of lights behind you or your patient should be avoided. A single color background, such as light blue, is likewise appropriate in examining your patients. Clutter should be avoided so that both of you can focus without distraction, no? As is a wobbly or even a shaky seat or table. No? And of course, we see a lot of this one. Camera angles is important as you will inspect the neck. You will not inspect for alar flaring, or you will not check for exophthalmos from this angle. But of course, sometimes you see patients carrying their cell phones with them while talking to you. So you ask your patients to sit down, prop up the monitor so that you can see them very well. Part of professionalism is to wear appropriate attire, as well as, of course, starting on time. Now, however, so dress professionally as you would in your clinic, and most of our elderly patients are actually conservative and would prefer you to wear your formal attire and white coats. However, light colors and white coats may increase reflection and glare on the digital screens. Now, while various noisy patterns and bright colors can look good on some people, definitely not on me, it may not translate well to the screen monitor. Maintain eye contact at all times. I mentioned this several times as part of your website manners. Your patient's clothing should allow the entire head and neck region to be visualized decently. We do not want to look at parts that we do not have to look at. And lastly, your hats and scarves should be removed while maintaining appropriate cultural and religious norms, no? Particularly for your Muslim patients. So who can accompany the patient during teleconsultation? There's a lot. Everyone wants to see you naturally, and especially this is true for our long-standing patients. Our patients' families are curious as to what really transpires during your clinic visits, and now feels that they can likewise listen in on your conversation under the guise of being concerned, or would also want to consult simultaneously. However, in obtaining the consent before the consultation, you should mutually agree on the companion, and the patient companion or caregiver is any family member or an individual authorized by the patient to represent him or herself. They may be involved in 2 settings. First, they can be present with the caregiver, or the caregiver is consulting on behalf of the patient if the patient is incapacitated either mentally or physically. So now that we have the essentials of conducting a teleconsultation, how exactly do we examine the patients? It is very disheartening that the thyroid, being the only endocrine gland, accessible to physical examination can only be examined by inspection at this time in telemedicine. Thus, it is important to brush up on your history taking and clinical acumen when you have patients for thyroid consult. One potential challenge, for example, in assessing a new thyrotoxic patient via telemedicine is determining the presence of hemodynamic instability. Examples of which are severe sinus tachycardia, or even atrial fibrillation, or even congestive heart failure. Although patients may have personal devices such as your smartphones, smartwatches, and even your sphygmomanometer capable of measuring pulse and blood pressure, their use for a formal medical evaluation has not been validated. However, of course, we always do with what we have, and any home data available should be collected and properly documented. The importance of a private, well-lit, quiet room cannot be overemphasized when you evaluate patients with thyroid disorders, because how they conduct themselves in front of the camera may give you a clue for any possible thyroid dysfunction. Is your patient fidgety, hot-tempered, wouldn't let you finish your questions first? Or do you see a very slowly moving patient just staring blankly at you, mouth open, and takes forever to answer your questions, or just answers with a yes or no, doc? You also look at other clues. For example, in the clothing. Clothing may be inappropriate for the current temperature. You may also check for any diaphoresis or any cold intolerance in the patient. You should also ask for any weight changes. And of course, hoarse voice caused by compression of the larynx due to the thyroid gland enlargement. For example, very rarely in thyroid malignancy can give you a clue as to what is happening to your patients. A sluggish bedroom voice or a low-pitch nasal quality voice may signify hypothyroidism. This is due to the accumulation of your hyaluronic acid that causes enlargement of the tongue and thickening of the pharyngeal as well as your laryngeal muscles. Dryness of the skin as well as eyebrow changes in hypothyroidism may be challenging to evaluate in our elderly patients, while they can similarly demonstrate apathetic hyperthyroidism. The myxedematous tissue is characteristically boggy and non-pitting and is apparent around the eyes, on the dorsa of the hands and feet, and in the supraclavicular fossae, and these may be present in full-blown hypothyroidism. Or your patient just may have gained weight. Now, aside from the common Graves' ophthalmopathy signs that we know, we may evaluate also for the following eponyms. No? In particular, the Geoffroy sign, the lack of wrinkling of the forehead when the patient looks upward, or your patient just might have had Botox. In the extremities, you may also evaluate for the followings, for acropatchy, which is similar in appearance to your finger clubbing, but caused by, of course, your periosteal phalangeal bone overgrowth. If your patients do not have their manicures done, you can check for your onycholysis, which is your painless detachment of the nail from the nail bed. Or you can also check for any pretibial myxedema, which is an accumulation of excess glycoaminoglycans in the dermis and subcutis, presenting in about less than 0.05% of hyperthyroid patients. And therefore, if you see them, probably there is true hyperthyroidism. How to check for peripheral tremor? Ask the patient to stretch their arms out in front, careful not to touch the camera. Place a piece of paper across the back of your patient's hands and observe for any evidence of quiver that will now translate to your peripheral tremor. Also, you can also check for your peripheral myopathy by asking the patient to stand from a sitting position with their arms crossed. So make sure to ask someone to stand close to the patient to prevent them from falling if you're going to do this maneuver. Inability to stand up would suggest proximal muscle weakness, which is again more prevalent in your hyperthyroid patients, particularly those who are initially presenting with hypokalemia. The William Shakespeare once said that the eyes are the windows to one's soul. In this case, they can also be windows to your patient's thyroid health. For your lid retraction, the sclera is visible between the upper lid margin and the corneal limbus. The upper eyelid retraction is the most common ocular sign of your Graves' disease and in other thyrotoxic states, such as your toxic multinodular goiter as well as toxic adenoma rarely. No, eyelid retraction is thought to occur due to sympathetic hyperactivity causing excessive contraction of your superior tarsal and levator palpebrae superioris muscle. For the exophthalmos, bulging of the eye anteriorly out of the orbit can be examined from front, from the side, and from above, and even from below if you want. Now, to identify exophthalmos, inspect the eye from different angles, and of course, bilateral exophthalmos usually develops in Graves' disease due to the edema and lymphocytic infiltration of the orbital fat, the connective tissue, and extraocular muscles. As thyroid doctors, I know you've seen a lot of patients also who have unilateral exophthalmos only. Okay, so just let me go back. No? So due to that lid retraction and exophthalmos, the eye is more prone to dryness and the development of conjunctival edema, as we see here, or conjunctivitis. And in severe cases, corneal ulceration. Depending on the severity, you should be able to determine when to refer these patients instead for a face-to-face consultation or even directly to the emergency room for IV glucocorticoid therapy. So assess for evidence of ophthalmoplegia or your restricted eye movement, as well as your diplopia and pain during eye movement. You check for lid lag, which is the delay in the descent of the upper eyelid in relation to the eyeball when looking downward, most commonly associated with Graves' disease. Of course, again, it may be rarely connected also with your toxic multinodular goiter or toxic adenoma. It is thought to occur secondary to combination of your lid retraction as well as your exophthalmos, and the maneuver is that you hold your finger superiorly and ask the patient to follow it with their eyes while keeping their head still. To move your finger downwards direction while observing your patient's upper eyelids as the patient's eyes follow your finger. There is lid lag if the upper eyelids will lag behind the eyes downward movement while the sclera being visible between the upper eyelid margin and your corneal limbus. So whether in telemedicine or in face-to-face consultation, the anatomical landmarks for thyroid inspections are the same. So here in the blue is your thyroid cartilage, and in red is your, of course, your cricoid cartilage. So you inspect the midline in a 90-degree angle. With your patient, you inspect the midline of the neck from the front and the side, noting for any masses or scars. So the normal thyroid gland should not be visible. We all know that. And the maneuver for further examination would be to ask the patient to swallow some water and observe the movement of the mass with or without hyperextension of the neck. Goiters and thyroglossal duct cysts typically, as we know, will move upwards with swallowing, and the lymph nodes will typically move very, very little, if at all, with your swallowing. An invasive thyroid malignancy may not, or very, of course, very, very huge goiters may not move with swallowing if tethered to your surrounding tissue. In general, a neck check is not considered the most accurate or reliable, no? As in this time of pandemic, and even in teleconsultation to identify your thyroid disorders or even your thyroid disease. However, it is fun to ask your patients, and it's also knowledgeable to ask your patients to do their thyroid self-examination, and even their family members to do their self-thyroid examination. And how do you advise your patients to do that? You ask them to stand in front of a mirror and focus on the lower portion of your neck, with your neck now slightly extended back. Take a sip of water and swallow. So as you swallow, you ask them, look for any enlargement, lumps, or protrusions, and remind them the thyroid gland is a butterfly-shaped organ situated just above the collarbone, or in our medical, the suprasternal notch, and below your larynx or the voice box. Place the 3 middle fingers along the midline of the neck below the chin, and go down, and the first hard structure that you will hit will be your thyroid cartilage. Now, as you continue to move your finger downward, you will feel or encounter next the cricoid ring. And then after that, 2 digits below the isthmus is the isthmus, or that is the tissue connecting both lobes of your thyroid gland, and gently move your fingers from that position laterally to feel the lobes of the thyroid. Now, you may be surprised that many of your patients and even their family members can actually learn how to palpate their own thyroid. No, as mentioned earlier, we can only do inspection in telemedicine. So try to document all these findings. No, for example, here I see a swelling in the anterior aspect, more to the left of the midline, in the region of the thyroid, measuring approximately 5 centimeters. You may ask the patient to get a ruler or a measuring tape and put it beside the evident mass. The lower border is seen. It moves with declination. It is oval in shape. The surface appears to be smooth. Margins are fairly defined. No skin over the swelling has no redness, scar, any sinus, or dilated vessels, and there are no visible pulsations. And the trachea from here appears to be midline. So you should document your findings in terms of inspection. It is important to note that features of hypothyroidism manifest indolently. So as you noticed, majority of the examinations earlier were on hyperthyroidism, whose symptoms may occur very acutely. Also, in small studies on thyroid symptomatology, we see that these signs and symptoms have actually low sensitivity in correctly identifying the presence of true hyperthyroidism or hypothyroidism. In fact, some of these are similarly felt by the controls here on the right panel or euthyroid patients. As mentioned earlier, most signs and symptoms that we usually ask to assess for hyperthyroidism have actually also low sensitivity, especially in the elderly who may present with apathetic hyperthyroidism. And so, as in face-to-face consultations, since diagnosis and management of thyroid disorders are largely based not only on clinical findings, but also on laboratory and ancillary procedures, it is important likewise to brush up now on your skills in interpreting your thyroid function tests as well as your ultrasound findings. And I would like to share with you some of these clinical pearls to ensure both you and your patients an effective and quality teleconsultation in the face of limitations, especially in the access to laboratory or ancillary findings. So your TSH or thyroid stimulating hormone and the thyroid hormones exist in a log linear relationship, such that small incremental changes in your T4 would result now to large incremental changes in the TSH in the opposite direction. TSH secretion is exquisitely sensitive to your plasma concentrations of your free thyroid hormones, providing an inherently indirect but precise barometer of thyroid hormone status, making it the single best screening test for thyroid hormone dysfunction in an intact hypothalamic pituitary thyroid axis. So if you're going to screen your patients who have no known thyroid disease, and if you're going to choose between your thyroid hormone and your TSH, TSH is, of course, the single best screening method in order to determine any thyroid dysfunction. Part of ensuring quality patient care, of course, with limited resources during this pandemic or even limited access to laboratory tests, is knowing when to ask them for follow-up to assess adequacy of treatment. And this slide illustrates the typical behavior of your TSH and T4 in Graves' disease. Now, upon start of therapy, your FT4 would go down, and therefore, in the first few weeks of therapy, we only check T4 levels to determine the response or adequacy of treatment dosage. Standards of care as outlined in the recommendations for hyperthyroidism are the same as in the pre-pandemic, although as you know, or as you've heard from Dr. Nemesio Nicodemus' lecture last Wednesday, there are minimal differences as dictated by the availability of resources. And what I'm talking about is, of course, the block and replace strategy or regimen in your patients with Graves' disease. TSH typically remains suppressed, no, in Graves' disease for even longer than 6 months, and usually goes up and normalize once your thyroid hormone levels become very low, as in the shaded part, no, reflecting depletion of both circulating and stored T4 levels. And therefore, when you see normalization of your TSH, be very cautious in adjusting your anti-thyroid drugs. Levothyroxine hormone replacement is only indicated when the patient has already entered the true hypothyroid phase without the effect of your anti-thyroid drugs. Of course, do keep in mind also the thyroid changes during pregnancy, as well as the normal thyroid function test values typical in each trimester. We have a study here for Filipinos. The treatment goals for hyperthyroidism and hypothyroidism are similar pre-pandemic, so you may adjust the frequency of your monitoring, not only based on these results, but also to the available resources, and more importantly, while considering the status or the general well-being of the mother and the baby. Although most thyroid function test patterns are easy to interpret and concordant with clinical assessment of your thyroid patients, a small but important subset of patients will exhibit results that will actually give you a 10/10 headache. No, because they are either discordant with the clinical picture that you are seeing on screen or not congruent with each other. In such cases, you may reevaluate their clinical history for the presence of these confounding variables that decide which test is discordant. What is important is to get a thorough history and examine your patients for clues. No? For thyroid nodules, most would prefer to defer your FNAB or surgery at this time. So it's imperative for you to examine the entire ultrasound report and not just the final impression to evaluate for features of potential malignancy or malignant features that will tell you that there is a suspicion for malignancy and you should do your FNAB. Okay, Dr. Pramono, in this article which came out in the journal European Federation of Endocrine Societies, just outlined these indicators for early or weeks pregnant patients with thyrotoxic and compressive symptoms presenting with a life-threatening condition for the mother and the fetus, and which cannot be controlled with your anti-thyroid drugs. And of course, goiters or with respiratory or already gastrointestinal compressive symptoms. Okay, narrowing everything down to the following important considerations in the management of thyroid disorders. Your COVID-19 pandemic for hypothyroid patients, really difference in terms of monitoring your hypothyroid patients at this time. For hyperthyroid patients, you should know any adverse reactions to the anti-thyroid drugs and differentiate the agranulocytosis or neutropenia with your COVID-19 infection. Know when to follow up after your dose adjustments with your patients. For thyroid nodules, the indications for FNAB have been extensively reviewed, as well as we have a very, very good discussion earlier with your thyroid cancer. So in conclusion, more information is actually needed to demonstrate conclusively that thyroid disorders can be effectively and safely cared for via telemedicine. This paradigm shift to virtual consultation has a learning curve and may strain the physician-patient relationship, and some of your patients may actually feel that they are receiving a substandard level of care due to the impersonal nature of telehealth as it lacks physical human interaction. However, Telemedicine maintains access to continuous health care of our patients with these chronic thyroid disorders, albeit with challenging limitations. And this lecture also, this lecture is actually a call for action to our specialty societies and experts to come up with guidance and best practices for Filipino physicians in managing patients with thyroid disorders via telemedicine during pandemic and most importantly, even beyond. Thank you very much for your rapt attention.
Thank you and congratulations, Dr. Laplano. That was indeed a remarkably informative, relevant, and helpful discussion. Let's proceed with the Q&A segment. So if it's okay with you, Doc, let me ask the first question.
Sure. Thank you.
So as physicians, we are used to doing history taking and physical assessment face-to-face. It has been our routine ever since like med school and internship. So Doc, now with the new normal, what are the challenges for you as a physician in taking care of your thyroid patients via telemedicine?
Well, thank you for that question. So actually for me, I've been following up already some of my patients via text or even by Viber or even by Messenger even before the pandemic. But of course, now we have to do with the audio-visual presentation of our patients. So some of the challenges that we encounter is, of course, as I mentioned earlier, this technology is a learning curve for most of us, especially in terms of time management during the initial phases of me conducting my telemedicine a few months since lockdown, since that would be the first time that I saw my patients or your patients saw you or any doctors, they have already accumulated all the complaints for several months. And that will take time when they tell you all the complaints that they will be telling you. And of course, it is very challenging to cut them off because of course, that will be the first time that they will say, that they will tell you all of these complaints. So a challenge is, of course, time management in terms of that and cutting and maximizing everything. And that's why one also of the challenges for that is also obtaining the previous medical records in terms of the quality of the picture that they will send to you. Sometimes there are blurry images. No, especially as thyroid physicians, we want to look at the plates or the films of the thyroid ultrasound. So sometimes if the pictures are blurry, or sometimes you would see a feet or a finger on top of the film. So it's a challenge for us to completely look at that. And also, as one tip I can give, so I always ask my patients to put a highlighter on the date, because sometimes they will give you all of these tests, and then you're going to interpret the test, and then once you are already consulting your patient with doc, that is already December of 2019 pa. So these are the challenges that you should be able to mitigate for a very effective and successful time management during your teleconsultation. Other challenges would be, of course, technical. Of course, sometimes you will see patients whom you will talk for a short while, and then their internet signal would go down, and so you should prepare to have a contingency plan of just calling them by phone. So to explain everything. So you may ask them, oh, is it okay to you to just talk to you over the phone? Anyway, I've already seen you and examined you. And that's why during the first few seconds or minutes that they will appear on screen is very important for inspection. Because somehow when their signal goes down, then you're already able to look at your patient very thoroughly. And then if their signal falters, then you can just talk to them. I noticed that you are fidgety or you are sweating a lot despite the heat, despite the coldness. So everything is a challenge. But of course, there are also advantages.
Oh, yes, Doc. There is a follow-up question, Doc, regarding with the challenges. So regarding with your consultation, how do you do the follow-up, Doc? How do you do scheduling of the follow-ups? Is it still the same with your face-to-face consultation, or do you alter the spacing of your follow-ups?
Yes, in particular thank you for that question. In particular for hypothyroid patients that are already stable in terms of their doses, and we do not see any foreseen factors that will change the absorption of their levothyroxine, and always assure that they have the specific brand that they are taking, because different brands have different absorptions and different reactions with our TSH with our patients. So for hypothyroid patients, before I used to practice every 3 or 6 months, or even 6 to 12 months. But now, some of my patients, I recommend to see them after 9 months, or even after 12 months, or even after 18 months, as long as they are stable for hypothyroid patients. For hyperthyroid patients, it is actually an individualized approach. If these are new patients, that I would ask them to follow up with me, either by audiovisual teleconsultation, or they can just send to me their laboratories maybe 2 to 4 weeks after the start of therapy, so that I can monitor them well. For those old patients whom I've already seen, and I can actually sort of predict how they will respond to my anti-thyroid medication drug adjustment, then I can just ask them to follow up for 6 to 8 weeks after drug dose adjustment. And then that follow-up can also be sometimes audiovisual, and most of the time that is already just by sending me text messages, and then I will just instruct it, oh, this time we're going to send me your laboratory after 4 to 6 weeks, and then I will recommend by SMS when we will see each other again via face-to-face or telemedicine or teleconsultation. For thyroid cancer, I follow what was already discussed earlier. No, it's an individualized approach. It depends on whether they are low risk or high risk malignancies. But together, even with thyroid nodules, together with that, I follow the guidance from our big organizations telling us regarding the safety of maybe deferring the radioactive iodine or the workup of those types of patients.
Yeah, so Doc, it really depends on the clinical condition and the stability of the patient. Look, regarding for teleconsultation also, how do you ask for the consent?
You ask, so it depends on if you're going to have a platform, your patients usually will sign the consent already because the platform will already do it for you. But if you're going to talk to your old patients and tell them, okay, we want a private consultation, do you want to do it via Viber or Zoom or Messenger, a teleconsultation? We have several formats for several consents. So it's the teleguidance for Filipino physicians by the UP College of Medicine Medical Informatics Unit have a sample form of the consent that you can ask your patients to sign first. And then if they have questions, they can discuss it with you, and then they sign it, and then they get a picture, and then they send it to you, so that you have proper documentation for the consent.
Okay. Doc, so in contrast with the challenges and difficulties, what are the advantages as a physician in taking care of your thyroid patient via telemedicine?
So we can follow up them more, right? And we can reach those patients that are actually in the remote areas and who are already having problems with transportation. For example, since I practice in the province, some of my patients will travel for 2 to 4 hours before they reach me. So in telemedicine, I can already just tell them to set up a teleconsultation, and then I can do those teleconsultations and follow them up more frequently as their condition will dictate. Also, I can look at the structure where they're coming from in terms of how the pharmacoeconomics, no? Because you can see their house, you can see everyone, the setup in the house, so you can evaluate all of that in your pharmacoeconomics. For example, for these thyroid patients, when to ask for your laboratory, when to ask for your ultrasound. So those are the advantages.
Okay. And docs, what are your tips, especially for us, we're new diplomates of endocrinology, we're still initiating our practice, and then we are challenged with this new normal in telemedicine. So what tips would you offer the other physicians to ensure a smooth teleconsultation for thyroid disorders?
Nako, siguro before I answer that tip, I saw some questions here in the chat box. No? So we will answer this. What here? Okay, so since COVID has affected face-to-face, do you consider spacing out your follow-up dates? Already been answered, or still follow the regular schedule It is now more, it depends on the adjustment and the individualization, of course. What guidelines would doctors consider to follow up with patients if any abnormality in the thyroid is suspected during teleconsultation? So it depends on what type of thyroid disorder, as mentioned for hypothyroidism, and if you have stable hypothyroid patients already on levothyroxine therapy, then the follow-up will be spaced out maybe 9 to 18 months across the board for those patients. For hyperthyroid patients, it depends on the level of their hyperthyroidism, their thyroid hormones, and of course what anti-thyroid medications or doses you will adjust for your patients. For patients with thyroid malignancies and thyroid nodules, also the decision to when to repeat the ultrasound. Of course, these are slow growing tumors. So maybe you will not be able to see any change in the size or in the number of thyroid nodules if you repeat them in 3 months. So the more short answer to this is that there's actually no specific black and white guideline for this follow-up of our patients. It's really up to us to look at the status of the patient in collaboration with what we saw in the biochemical as well as in the ancillary before we advise them. And that's why at the end of my lecture, I said that this is actually a very good call for action to our experts to come up with a guidance, not really guidelines, but guidance in terms of monitoring our Filipino physicians in their monitoring of thyroid dysfunction. So any concerns from overseas Filipino workers? No. And of course, legally and ethically, it is said that we should be, the telemedicine consultation should be within the country where you are actually practicing. Yan. So for the tips, last tips na lang. No? So, last tips na lang. No? So for the tips, always for the trend, there are laboratories that are very good in terms of giving you a report of the previous trends of the laboratory. So that's very good. You may want to ask your patients to ask if their laboratory can do that for you. You get the different values from the previous and then they will line it up. Second, ayun, I put my highlighter in the dates, so that they will know, I would immediately, and then I will ask them to look at their, once after taking the pictures, you look at the pictures that you have taken and make sure that you can read them well. If not, they are blurry and therefore you should do it again before you send it to me. So that is very clear for both of us. And of course, during the consultation, it's very good to always keep in mind the website manners in terms of stopping the conversation or, ma'am, I'm sorry, but we have other patients waiting, as in the face-to-face consultation with the other patients waiting. But of course, let me address your more important questions. So these are all part of an effective and relevant telemedicine strategy at this time. And you know, Riz, I don't think that telemedicine will be it will be part of our thyroid patients, no, as part of our practice and not just during this pandemic. So it is very important to really brush up on our history taking, clinical acumen, and our knowledge of the interpretation of the thyroid function test so that we will be managing these patients very well even after the pandemic through telemedicine.
Okay, thank you. Thank you so much, Dr. Laplano. So in the interest of time, as much as we want to extend this segment, thank you and congratulations, Dr. Laplano. It was really a very interesting and very informative discussion on telemedicine. It really helped, it really helped me, and I know most of the physicians as well who are listening to tonight. Thank you so much, Dr. Laplano.
Thank you, everyone.
So I will give the floor to Dr. Robles.
Thank you, Riz, and thank you, Eric. I think that it was really a fitting end to our series of lectures for this past week. No, so we've had 3 days of the Philippine Thyroid Association. Unfortunately, we have to put the final word with regard to our convention. And before we actually end, we have a closing ceremony. And I'd like to call on, of course, our president, Dr. Nemencio Nicodemus. He will be joined by our vice president, Dr. Eric Cruz, and we will move forward with the awarding of certificates to our partners, Nemi and Eric.
Yes, thank you very much, Jeremy. I'm very
Let me
happy
share with
that
you the slides,
our
Nemsa. Yeah.
yes, please. I'm very happy that we have finished our first virtual annual convention for the Philippine Thyroid Association, and we are very thankful to everyone who has attended our 3 days. And of course, this successful virtual conference will not be made possible without the support from our friends and from our partners. And at this point, I would like to award our certificate of appreciation to one pharma partner who has supported us greatly in this first virtual convention. And if I may see the, will we flash the certificate? Okay. So, okay. So our first certificate of appreciation is given to our pharma partner, Merck, for their invaluable support to our organization during the virtual 36th Annual Scientific Meeting and Convention of the Philippine Thyroid Association with the theme Contingencies and Strategies for Thyroid Disease Management in the Time of a Pandemic. Thank you very much, Merck, for your support. Here is Dr. for our next certificate.
Hello. So we award the next certificate to our platform provider, the Telemedicine Network of the Philippines. Thank you very much for your invaluable support to our organization during this 36th Virtual Annual Scientific Meeting Convention with the theme Contingencies and Strategies for Thyroid Disease Management in the Time of a Pandemic. Thank you very much, TNP.
Thank you, Nemi, and thank you, Dr. Eric, as well. We now proceed to the awarding of certificates to the speakers and moderators. May I now ask Dr. Francis Estrada and Dr. Eric Mendoza to present the certificates to our moderators as well as our speakers.
So thank you, Dr. Jer. We will now award our certificate of appreciation to our speakers and moderators. We will first award for the first lecturer. We will like to award the certificate of appreciation to Dr. Bien Matawaran as for being a speaker for his lecture on the COVID-19 and its impact on the thyroid gland. We'd also like to award the certificate of appreciation to Dr. Annalyn Galia Gabuay for being the moderator for this lecture. We'd also like to award the certificate of appreciation to our the speaker of the second lecture to Dr. Robert Sarmiento for his lecture on the surgical priorities during and beyond the pandemic. And this was moderated by Dr. Ida Marie Tabangay Lim on the second day. Another certificate of appreciation is awarded to Dr. Thomas Neil Pascual for his lecture on the impact of COVID-19 in the practice of nuclear medicine. And his lecture was moderated by Dr. Charles Tan on that day. We again award the certificate of appreciation to our speaker to Dr. Nemencio Nicodemus for his lecture on managing hyperthyroidism during the time of COVID-19. We likewise award the certificate of appreciation to Dr. Alta Gracia Damalerio for moderating this lecture. The next certificate of appreciation is awarded to Dr. Jeremy Jones Robles for his lecture on managing thyroid disease in pregnancy in the COVID-19 pandemic. The Certificate of Appreciation is likewise awarded to Dr. Raquel Bruno for being the moderator for this lecture. Next certificate is awarded to Dr. Eric Mendoza for his lecture on the care for the hypothyroid patients in the pandemic. And another certificate is awarded to Dr. Arabel Liputan for being the moderator of this lecture. The next certificate is awarded to Dr. Schoberg Go for his lecture on the thyroid malignancy in the time of COVID-19. Likewise, a certificate of appreciation is also awarded to Dr. Wenceslao Lauderes for his lecture on the thyroid malignancy in the time of COVID-19. And we also award the certificate of appreciation to Dr. Silvernon Israel for moderating this lecture. We award another certificate of appreciation to Dr. Jeffrey Domino for his lecture on robotic surgery in thyroid disease in the time of COVID-19. We likewise recognize Dr. Doming Sampang for being the moderator of his lecture. And last but not the least, we award the Certificate of Appreciation to Dr. Nestor Eric Laplano for his lecture on telemedicine and teleconsult strategies for thyroid patients. And we likewise recognize Dr. Ariza Crisan Soria for being the moderator for this lecture.
Thank you, Dr. Francis Estrada and Dr. Eric Mendoza. We now proceed to the recognition of the new members of the Philippine Thyroid Association. This will be led by Dr. Arnel Pauco, who will also be giving us the oath for membership for the PTA.
Good afternoon. We have come to the part of the program where we will welcome new members of the Philippine Thyroid Association. I invite the following doctors whose name I will mention and who have submitted their application and oath of member form to open their cameras and microphones for their induction as our new members. I call on Dr. Emmy Akayan, Dr. Cheryl Adriano, Dr. Neil Aquino, Dr. Ana Arceliana, Dr. John Paul Bagos, Dr. Dionise Bawal, Dr. Giselle Bedia, Dr. Raquel Cabatu, Dr. Marilyn Caro, Dr. Bernie Katangi, Dr. Emeline Caverte, Dr. Shena Rose Chavez, Dr. Harold Chiu, Dr. Maria Nikki Cruz, Dr. Altagracia Damalerio, Dr. Heidelin Dominguez, Dr. Darius Enario, Dr. Luz Margaret Escueta, Dr. Ernest Solomon Estanislao, Dr. Joy Flores, Dr. Mario Augusto Goco, Dr. Maria Belen Hizon, Dr. Silvernon Israel, Dr. Alexis Laforteza, Dr. Arabel Libutan, Dr. Ninwell Luna, Dr. Franz Magnaye, Dr. Angeli Ong, Dr. Jennifer Nang, Dr. Antonio Pescador, Dr. Bernie Piodos, Dr. Jeril Sahagun, Dr. Mary Ann Samson, Dr. Faith Santos Caratao, Dr. Jim Sagat, Dr. Jesus Season Jr., Dr. Arisa Soria, Dr. Charles Tan, Dr. Dickinson Tan, Dr. Gerard Ian Tan, Dr. John Ryan VR, Dr. Christian Dominic Yu, and lastly, Dr. Sachi Yumul. Okay, doctors, can you all hear me?
Yeah.
Yes.
Okay, kindly raise your hand, your right hand, and repeat after me. I state your name.
I,
I,
Season Junior,
Margaret Escueta,
Having been elected as member
having been accepted as member
member
of the Philippine Thyroid Association
of the Philippine
Thyroid
Thyroid Association,
Association,
do hereby solemnly swear
do
do
hereby
hereby
solemnly
solemnly
swear
to abide by and uphold the Constitution
to
to
abide
abide
by
by
and
by
and
and uphold the
uphold the
Constitution
Constitution
and bylaws of the association,
and
and
bylaws of the
bylaws of the
association,
association,
to perform my duties as member of the association
to
to
perform
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 my
my
as
duties
duties
as
member
as
of
member
the
of
a
the
member of the
association
association
to the best of my ability and capacities,
to
to
the
the best of my ability and
and
capacities,
capacities
without fear or favor,
without
without fear or favor,
with the aim of furthering the purpose
with
the
the
aim
aim
of
of
aim of
furthering the
furthering the
purpose
purpose
and advocacies of the association
and
and
advocacies of the
advocacy
advocacies of the
association
association,
and advancing the interest of the community to which it is dedicated,
and
and
advancing
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 the
the interest
interest
of
of
the
the
community
which
community
it
to
is
which
to
it is
which it
dedicated.
is
dedicated,
dedicated,
to support all the projects of the association
to
to support
support
all the
all the
projects
projects of the association,
and to conduct myself in a manner befitting a member,
To,
and
to
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 conduct
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 myself
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 in
in
a
a
manner
manner
befitting a
befitting
manner
a
member,
member,
befitting a member,
so as to bring honor and prestige to the Philippine Thyroid Association.
so
so
as to
as
bring
to
honor
bring
and
honor and
prestige to the
prestige
Philippine
to
Thyroid
the
Thyroid
Association.
Philippine
Association.
Thyroid Association.
I take this pledge without mental reservation or purpose of
I
evasion.
take this
I
pledge
take this pledge without mental
without mental
reservation or
reservation
purpose
Purpose
of
of
evasion.
evasion.
So help me God.
So help me God.
God.
Okay, congratulations, doctors.
Thank
Give
you.
yourselves a warm round of applause and welcome to the Philippine
Thank
Thyroid Association. We hope to see you in the future activities of the organization. Thank
Maraming
you.
salamat.
you.
Thank you.
Thank you, sir.
Thank you, Dr. Arnel Pauco, and welcome to the new members of the PTA. Of course, it is a joy for us to have you in the team. We will have a lot of activities set for the rest of the year, so please stay tuned. We will inform you if we have upcoming activities, particularly webcast and web seminars that will give us more information on how to handle the current situation, especially in the background of COVID. Of course, we do a lot of collaborative activities with other organizations, and we're pretty sure that you will learn a lot. And we hope that on your end, you can also help us promote the Philippine Thyroid Association. We've now come to the point that we would like you to know the officers as well as the board of trustees for the PTA. So I'd like to call in Dr. Eric Cruz give us to introduce us to the officers and board of the Philippine Thyroid Association.
Thank you very much, Dr. Jer. I am Dr. Eric Cruz, the current Vice President of the PTA. And let me acknowledge and thank our President, Dr. Nemencio Nicodemus Jr., whose leadership, especially in these challenging times of the pandemic, is extremely commendable. Thank you, Mr. President, for leading us and setting us towards a bankable direction where we see light in the management of benign and malignant thyroid diseases amid COVID. Let me thank our reliable and dependable Secretary, Dr. Arnel Pauco, who made a lot of things easier for all of us, especially during our pre-convention preparations. Thank you, Arnel. Our Treasurer and Convention Chair, Dr. Jeremy Robles, congratulations and thank you for the excellent program for gathering these expert and esteemed speakers and moderators who spoke about things that were extremely helpful, educational, and relevant. Our PRO, Dr. Jeffrey Domino, our tech guy, and link to our platform provider. We thank you for giving us the ability to broadcast what PTA would like to share and show, and enabled us to reach our audience, those in the medical profession and the lay. Our hardworking, knowledgeable, and reputable board of directors, Drs. Francis Estrada, Ida Lim, and Eric Mendoza, Dr. Wesley Lauderes, our kuya and immediate past president, thank you for your help. Ma'am Susan Conquilla, our secretariat, proven na talaga ma'am, maasahan sa lahat ng bagay at ever ready. Thank you. And last but not the least, let me thank all of our past presidents and officers for setting the bar for the inspiration and guidance. And to all of you, including our industry partners, thank you very much for gracing and supporting the PTA's first virtual annual convention. Good evening po. Back to you, Dr. Jer.
Thank you, Eric. At this point, I'd like to invite, of course, our tech guy, Dr. Jeff Domino, to invite all of the other participants who are not yet members of the PTA to actually join us, no, for our activities. I'm pretty sure that you will enjoy your membership. You will be able to learn a lot from this group. Jeff?
Yes, Jeremy, thank you very much, and welcome to the new to the new members. Welcome to PTA. I'm pretty sure you're gonna enjoy this. This is actually a collaboration of different specialties, all disciplines that are really practicing in the management of thyroid. So first of all, I'd like to thank our president, Dr. Nemi, our vice president, and Jeremy, especially Jeremy, for making our program. He's the scientific chairman for this, and congratulations also. So yes, Jeremy, I think it's I'm okay here. I'm back to you.
Thank you so much, Jeff. As what Jeff mentioned, no, the PTA is an organization with the thyroid in the middle of everything. Our focus here primarily is to make sure that people understand how significant this organ is and how important it is that we manage our cases appropriately with regard to the thyroid. Okay, so at this point, I think that maybe we can have a few words with Dr. Nicodemus before I close the program. Dr. Nemi?
Then after that, picture taking siguro tayo.
Yes. Okay. Mukhang naka-mute si Nemi. So anyway, at this point, I think this would be the best time for us to have the picture taking, siguro, Jeff? Huh?
Yes, so we'd like to invite everyone in the panel now to open up your videos. That will include the new members, so that this is our virtual picture taking. Alvin, pa-picture na lang. Thank you. Okay. Please open up your videos. And smile.
Okay. 1, 2, 3. One more. Second. 1, 2, 3. Okay.
Okay, thank you. Thank you, Alvin.
Thank you. Okay, so thank you again. I think we have reached the point that we are finally ending our 3-day convention. So you know that we've split the convention into 3 days of the week. That's a Monday, Wednesday, and Friday. This is the first time that we're actually doing it. There's a lot of firsts during this convention. Of course, it's the first time that we talked about strategies as well as contingencies, especially because we are faced with a pandemic and the situation is quite difficult. No, it's easy to make a program, but the program will not work if you do not have dedicated and very good speakers as well as moderators and people around you who support you for this particular program to be a success. So I want to thank speakers, our moderators, our staff, the board, as well as the officers of PTA, and of course our secretariat, Dr. So actually Susan Conquilla, because we refer to her doctor already, because she knows a lot about the medical aspects of the topics that we have discussed. No? So Susan is our secretariat. She's been a big help to all of us. And of course, I want to thank the partnership that we have with MedSynapse, who's actually made this possible for us to project or share this particular conference with the rest of our delegates outside of the Philippines, and that includes areas in the Middle East as well as that of the Asia and the Pacific region. So I want to thank all of you for joining us in the PTA, and we hope that you will continue to support this organization and watch out for our next activities that we have lined up for the year. So of course, we will keep in touch with you. So once again, I want to thank you. Before I leave, I would like to extend one more invitation to all of our members. It is an invitation for you to join us in another convention. Of course, as you may know, I am the president of the Philippine Society of Endocrinology, Diabetes and Metabolism, and I'm extending the invitation for all of you to join us for another international convention. This is the 2021 annual convention of the PSEDM. The theme for this year is Hope, and it's aptly titled Hope, Health Optimization and Progress in Endocrinology. This is going to be on March 18 to 20. That's 3 days. And then we will have a full house of speakers of more than 40 lectures. We've established international collaborations with a lot of the speakers coming in from the US, Europe, as well as in Asia. As you can see, some of the more familiar faces will be lecturing for the plenary lectures. You have more lectures, as well as your favorite speakers from the Philippines joining us in the breakout session. So international collaboration, digital presence, shared solutions. We've also reflected that in the PTA, and now I'm extending this invitation for you to join us for the PSEDM. So it's virtual, it's also free, and it's open for registration. So once again, in behalf of our president, Dr. Nemencio Nicodemus, as well as the board and the officers of the PTA, I want to thank all of you for joining us for the annual convention of PTA. This is your host, as well as your scientific chair. I'm Dr. Jeremy Robles, joining you from Cebu, and hoping that you will continue to support the PTA. Maraming salamat po. Thank you and good evening.
Congratulations, Jeremy.
Thank you.
Congrats, Dr.
At last.
Congrats, Dr.
Thank you, everyone.
Congratulations, Dr.
Congratulations to all of us.
Hey, thank you
Maraming
for
salamat.
inviting
Thank you
us
for our
to speak.
speakers.
Congratulations.